Good afternoon. Welcome back, ladies and gentlemen. I hope you are well rested and have been well fed after that lunch break. I think we're going to move straight on into the afternoon session, and I'd firstly like to introduce my consultant colleague and good friend, Dr. Matthew Banks from University College Hospital, who's joining me for the session today, but also Dr. Prasad Iyer, who it's a privilege to invite to ONM this year. He's a professor of gastroenterology at the Mayo Clinic in Rochester and has a wealth of experience in Barrett's esophagus. And we're really going to focus this afternoon session on looking at tissue sampling methods to help us select appropriate patients for endoscopic eradication therapy in Barrett's. Prasad, I really appreciate the effort you've made and the time difference that there is, and joining us today, Prasad.
Thank you so much, Vinay and Matthew. It's a pleasure, and thankfully it's 7:30 in the morning in Minnesota, so I think we are good. It's a nice day to begin. Nice way to begin the day.
Great. Well, Prasad, what we'll do here is we'll go straight into your excellent lecture, and then we'll have a chat afterwards between the three of us and scratch our chins and see what we can come up with. Okay. So can we please go to the recorded lecture from Prasad.
Hello, everyone. I'm Prasad Iyer from the Mayo Clinic in Rochester, and it's a pleasure for me to participate in ONM 2023. The topic assigned to me is to provide an update on tissue sampling methods in Barrett's esophagus. And I would like to begin by thanking the organizers, particularly Dr. Sehgal, for his kind invitation. So a brief outline of my talk. We will first begin by understanding the rationale for the detection of dysplasia by endoscopic surveillance, including a couple slides on best practices, followed by understanding some of the limitations of endoscopic surveillance as currently practiced, and some evidence on its modest effectiveness and some underlying reasoning behind this. And then finally move on to some of the newer non-biopsy techniques that have emerged or are emerging in the last few years, including a discussion on wide area transepithelial sampling, a combination approach of brushings with biomarkers, and brushings are endoscopic brushings. And we will finish with some recent provocative data using a combination of sampling the Barrett's mucosa with a cell collection device like the Cytosponge in combination with biomarkers, both histopathological as well as clinical biomarkers. So our current Barrett's esophagus to esophageal adenocarcinoma paradigm consists of the following components. We believe that patients who are at risk, and there are several risk factors that I have outlined here, develop Barrett's esophagus, which is a metaplastic condition of the distal esophagus where the epithelium is replaced by, the squamous epithelium is replaced by columnar intestinalized epithelium, which then progresses via the development of dysplasia, low-grade and high-grade dysplasia to adenocarcinoma. And we really have three approaches to intervene at different stages and influence this cascade, if we could call it that. The first is to screen for Barrett's esophagus in those with risk factors, followed by endoscopic surveillance in those with Barrett's to detect prevalent low-grade or high-grade dysplasia or even adenocarcinoma, and then hopefully intervene endoscopically to prevent this transition of Barrett's to esophageal adenocarcinoma. So first and foremost, when we jump into endoscopic surveillance, we all need to be on the same page in terms of how do we actually define Barrett's and how do we inspect Barrett's. And this was a very nice video that Dr. Raghunath has shared with me. And again, as you can see, we are making a pullback from the proximal stomach into the esophagus. We are defining the diaphragmatic hiatus, which is our lowermost landmark, followed by the gastroesophageal junction, which we typically define as the top of the gastric folds. And then we then move proximally, pulling back. And as you can see, the mucosa has been cleaned. It is free of mucus, debris, saliva, performing a careful evaluation as we move proximally under high definition white light imaging. And then we establish the top of the Barrett segment, both in terms of a circumferential extent and the maximal extent. So this is something that all of us should be following and allows us to speak in the same language. So the first principle I would like to emphasize is during inspection, we need to look more and perhaps biopsy less. The intent is not to really reduce the number of biopsies, but to make our biopsies more informative and more targeted. So as I mentioned before, we want to watch the Barrett segment of any mucus or secretions. We could use water combined with a simethicone solution. I typically will use a soft cap, particularly if I know the patient has a prior history of dysplasia. This enables us to fix the mucosa, the focal length, and expose subtle lesions. We want to inspect with high-resolution white light imaging and some component of electronic chromoendoscopy or even dye-based chromoendoscopy. And then as I demonstrated before, we want to have a systematic examination. Again, distal to proximal is what I do. But again, we have to have our own method. And obviously, we would do two pullbacks, one with white light and one with any form of chromoendoscopy that we are most comfortable with. Other tips are to avoid overinflation, miss subtle, otherwise you will end up missing subtle lesions as shown in the picture here. If you were to overinflate, subtle lesions are going to be flat. We want to inspect in the retrograde position as well, because sometimes the cardia is difficult to evaluate, especially if we have a large hiatal hernia. And then when we perform a close retroflexion, we are actually seeing these lesions end on. We want to give ourselves adequate time. There is a concept of Barrett's inspection time that has been raised in one paper of at least 1 minute per centimeter of Barrett's mucosa, which was correlated with finding more visible lesions and high-grade dysplasia, though to be noted, this was in a very selected enriched population. Of course, as I alluded to, before we take biopsies, we should be inspecting the Barrett segment using any kind of chromoendoscopy. I think acetic acid is the most popular one, high sensitivity and specificity, or chromoendoscopy, which could either be optical or digital. And these are by and large linked to the manufacture of the endoscopes, and different technologies are available, narrowband imaging, blue laser imaging, eye scan optical enhancement, which are optical technologies. And then we have some which involve post-image acquisition processing. And then, of course, if you are able to find a visible lesion, you can then hone in with some magnification if that is accessible to you. In the United States, we only have digital magnification and not optical magnification, but I believe these technologies are available in the United Kingdom and Europe. Of course, we know that if we were to use electronic chromoendoscopy or dye-based chromoendoscopy, we actually increase our dysplasia yield by almost a third. This was in a systematic review and meta-analysis, which was published about 10 years ago. So what did we say in the most recent American College of Gastroenterology guidelines published just late in the middle of last year? Again, this is reiteration: perform careful surveillance with high-resolution endoscopes, high-definition monitors. You should get proficient at some kind of chromoendoscopy. And of course, the goal of all of this is to identify visible lesions. Visible lesions can be flat, they can be elevated, they can be depressed. And the idea is to sample them separately. Now, how do you sample them? You can either use a biopsy forceps, or you can perform endoscopic resection, depending on the level of local expertise that you have at your center. Once these focal abnormalities are sampled in different bottles, you should then proceed with the Seattle protocol biopsies, which are essentially surveillance biopsies obtained every 4 quadrant, every 1 to 2 centimeters, depending on the presence or absence of prior dysplasia. So if you have no dysplasia, you can go every 2 centimeters. If you have prior dysplasia, you would go every 1 centimeter. And studies have shown that this improves the rate of dysplasia detection. And of course, something to reiterate is that if you do find dysplasia, particularly in the community, then given the evidence of overcalls in the community, you always want to get this confirmed by a GI pathologist before you act on the dysplasia and begin endoscopic eradication therapy. Now, why is this so important? This is important because dysplasia is currently the sole determinant of whether we either recommend surveillance or we begin to initiate endoscopic eradication therapy. And this is really based on the risk of progression with no dysplasia, which is the lowest. Low-grade dysplasia is somewhere in between, and high-grade dysplasia is the highest. And studies have shown that when we perform endoscopic therapy in low or high-grade dysplasia, we can actually prevent progression to high-grade dysplasia or cancer. Now, this is all well said and done, but we know that there are several challenges in endoscopic surveillance. So the first challenge is that visible abnormalities are occasionally prominent, like this, a depressed lesion, or like this, an elevated lesion, but more often than not, they are subtle. And you really have to spend your time cleaning the esophagus, examining the esophagus in white light and narrowband imaging, and really picking up some of these subtle lesions. We also know that, unfortunately, endoscopists are under a lot of time pressure, and their compliance is not the best. So this was a paper that is now almost 15 years old, which highlighted the scope of this problem in a national pathology database and showed that endoscopists were really only about 50% compliant, even with the biopsy recommendations of every 2 centimeters. And in fact, what made matters worse is that this decrease with longer Barrett segment length. As you can see, the compliance actually drops to almost 10% if the length is more than 9 centimeters. And of course, this is not without consequence. If you are non-adherent, your risk of dysplasia detection, your odds of dysplasia detection are actually cut in half. This is also linked directly to the patchy distribution of dysplasia in Barrett segments. This was a very painstaking pathology esophagectomy mapping study performed by one of the Mayo Clinic pathologists, who mapped the distribution of no dysplasia, low-grade dysplasia, high-grade dysplasia, and cancer. And as you can see, sometimes there is green is high-grade dysplasia and red is cancer. Very occasionally, you will find large segments of high-grade dysplasia, but more often than not, they are scattered in a sea of low-grade dysplasia, or sometimes in a sea of non-dysplastic Barrett's, and you really have to find that little focus of high-grade dysplasia or cancer. And the other thing to also note is that even when we sample the Barrett segment and we follow all our guidelines of targeted biopsies and Seattle protocol biopsies, we are really only sampling about 5 to 8% of the entire Barrett segment. This is not without consequence. This was a paper that we published a few years ago in gastroenterology, where we looked at the magnitude of missed esophageal adenocarcinoma or high-grade dysplasia, which we defined as the detection of high-grade dysplasia or cancer within a year of non-dysplastic or low-grade dysplasia surveillance results. And as you can see, almost a third of all cancers or high-grade dysplasia were missed at the time of their Barrett's diagnosis. And this, of course, leads to this modest effect of endoscopic surveillance. This is another systematic review and meta-analysis we published in Gastroenterology, where we looked at both cohort studies and case control studies to look at the effectiveness of endoscopic surveillance in terms of adenocarcinoma-related mortality, adenocarcinoma-related stage. And what we found was that the performing endoscopic surveillance, there are obviously no randomized trials available at this moment. In these observational studies, surveillance is really associated with a rather modest benefit in esophageal adenocarcinoma mortality. And indeed, when we adjusted for length and lead time biases, these modest benefits were significantly attenuated or in some instances even eliminated. So again, the effectiveness of what we are doing is still fairly borderline as well. So all of this leads us to the question as to how can we improve the sampling of the Barrett's mucosa. And again, this is a picture that I'm putting up. This is how you would take your 4-quadrant biopsies, and you can see there are large parts of the mucosa that I've highlighted with these blue bars, and I could have put more blue bars here, which are really not being sampled. So how can we reduce sampling error? And this is where the first technology I'd like to highlight comes in, which is wide area transepithelial sampling. And really, this the technology is well described in its title. So this is performing endoscopic brushings, and I have a video as the next slide, and you will see how exactly this is done. This is an endoscopic brush, but unlike our regular cytology brush, this is actually a little longer. It is stiffer and has bigger bristles, which are then essentially put in contact with the mucosa, and you can actually sample large parts of the Barrett's mucosa, and then these are put on slides, and these slides are then reviewed by first an artificial neural network program, which then creates a collated three-dimensional image. That's why this is called Watts 3D, which is then presented to a pathologist, and the pathologist now has to look at about 200 images per sample, which have been selected by this neural network program. And then the pathologist can actually look for the presence or absence of dysplasia. So this technology has two components. Number one, it improves the sampling of the Barrett's mucosa, and secondly, provides artificial intelligence assistance for the pathologist in making dysplasia assessment more focused and more efficient. So again, this is a video. As I said, this is a brush which is passed through the biopsy channel of the endoscope. And once it is out, you advance this to the Barrett's mucosa. This was a video I took from a recently published paper in Endoscopy. And you can actually move the brush back and forth. And now, as you can see, you are sampling large parts of the Barrett's mucosa, and the goal is to A, reduce sampling error, and B, to obtain some deeper biopsy and cytological specimens. So how well does this do? This was a systematic review and meta-analysis that we published last year in Gastrointestinal Endoscopy, where we looked at close to seven studies with over 3,000 patients. And we looked at what was the incremental yield of dysplasia, any dysplasia. So the yellow bars are talking about any dysplasia. The orange bars are talking about high-grade dysplasia and cancer. And as you can see, the average yield of dysplasia goes up from about 16%. You can add about 7% on top of that. So about 50% increase in the detection of any dysplasia. When you hone this down to high-grade or cancer, you're looking at almost a doubling of the high-grade dysplasia and cancer. However, there are some issues with the data from Watts 3D papers. You should also note that though the detection of dysplasia goes up, there is Watts does not pick up all dysplasia. when it is compared with forceps biopsies as well, there is a false negative rate of almost 62% with Watts 3D. The second issue you should be aware of is that most incremental dysplasia yield is not confirmed by forceps biopsies in these studies. And of course, we have limited data to know whether the Watts only low-grade dysplasia or high-grade dysplasia has the same risk of progression as forceps biopsies, low-grade and high-grade dysplasia. And as you can see, there was a wide discrepancy between the total dysplasia and the high-grade dysplasia, the incremental yield, and that is because of the large proportion of Watts dysplasia being reported as crypt dysplasia, on which we have limited data in terms of its diagnostic criteria and significance. And of course, importantly, most of this pathology has been read only by pathologists employed by the company, and therefore we are still waiting for data on how generalizable these results are. There is some limited data published by Dr. Shaheen in GI endoscopy. This was a retrospective cohort of patients with Watts 3D, no dysplasia or low-grade dysplasia, who were followed in a database. And again, as you can see, the rate of progression with non-dysplastic Watts 3D was very low, and it was higher in the low-grade dysplasia Watts 3D reads. Of note, the numbers of progressors were extremely small, and the total number of samples with low-grade dysplasia was also very small. I would be remiss if I did not point to a recent multi-center randomized study that was published in endoscopy, and several Barrett's luminaries, including Dr. Hedry, were part of this study. And as you can see, this was randomized, wherein patients with low-grade or high-grade dysplasia and Barrett's were randomized to either Watts followed by biopsy or biopsy followed by Watts. And their diagnostic yield was actually compared. And no surprise that there are patients who are biopsy negative but Watts positive. On the other hand, there are also patients who are biopsy positive but Watts negative. So you can see that dysplasia is missed on both sides. And the investigators concluded that though the combination of Watts and forceps biopsies did increase dysplasia detection in a population of Barrett's patients enriched for dysplasia, there was no statistically significant difference between Watts and forceps biopsies for the detection of high-grade or cancer as its own single modality. So what are some considerations to keep in mind? As I alluded to before, you do get false negatives with Watts 3D, meaning the biopsies are positive, but Watts is negative. So hence, it should be used at the moment as an adjunct with the Seattle protocol. We would recommend reconfirming Watts only low-grade, high-grade, or esophageal cancer with forceps biopsies in follow-up endoscopy before you embark on endoscopic therapy. And lastly, that the significance of crypt dysplasia is really unclear, and we need more data. So it was for all these reasons that the Barrett's guidelines did not make a recommendation for the use of Watts 3D at the current time in endoscopic surveillance of Barrett's. Now, the next component I want to talk to are the possibility of combining brushing samples, and these are brushes that are obtained using conventional cytology brushes with biomarkers. And this was a study that we were a part of, led by Dr. Chuck at Case Western. And essentially, the brushing samples were actually used to develop a genome aneuploidy score, acronym of GAS. And this was combined with the real-seq analysis for the presence of gains or losses of certain chromosome segments. And patients could actually then be classified as not bad, maybe bad, or very bad. Again, this is very bad essentially consists of not only aneuploidy, but also gains and losses of some of these chromosomal loci, which have been shown to be present in esophageal cancer. And this category was shown to be correlated very highly with the presence of high-grade dysplasia or cancer. Most of the non-dysplastic Barrett's actually had no aneuploidy and no losses of or gains of chromosomal loci. So again, this is something that is probably coming down the pike. The last component possibility of sampling is to actually use cytology samples obtained by sponge-like sampling devices. Of course, the Cytosponge was developed in the United Kingdom by Dr. Fitzgerald. And in addition to detecting Barrett's alone, her team put together a training and a validation cohort to develop a classification of high-risk Barrett's, which they defined as the presence of either atypia on the cytology samples or the presence of p53 overexpression as detected by immunohistochemistry. And they divided patients into either a high-risk pool, which was biomarker positive, moderate risk pool, which only included clinical risk factors like long segment Barrett's, male sex or age over the age of 60, or a low risk group wherein neither biomarkers nor clinical risk factors were present. And in the training and validation sets, they found that low risk patients did not have, had mostly non-dysplastic Barrett's, and high risk patients had a high proportion of high-grade dysplasia or intramucosal cancer with a sensitivity of almost 0.94. And then they actually implemented this, algorithm, so to speak, in 223 patients, wherein only those who were biomarker positive, remember this was atypia or p53 positive, on the Cytosponge samples were actually taken up for endoscopy, showing that up to 30 to 44% of them had dysplasia, high-grade dysplasia, or intramucosal cancer. At a later stage, those in the biomarker negative category were found to have a very low prevalence of high-grade dysplasia or intramucosal cancer. This, of course, needs to be refined further, but does open the doors for some kind of risk stratification on the basis of biomarkers that are being assayed on just cell collection device samples. So in summary, I think it is important to remember that Barrett's surveillance still involves cleaning the mucosa, carefully inspecting with high-resolution white light imaging and some form of chromoendoscopy. We still need to sample adequately with biopsies and or endoscopic resection and a Seattle protocol. But there are several novel Barrett sampling technologies on the horizon, including Watts 3D, biomarker panels, which could be used on endoscopic brushings or on Cytosponge or other cell collection device related samples. Thank you so much.
Thank you so much, Prasad. That was a really elegant and helpful update on tissue sampling in Barrett's, and I think it was a much needed update for all of us. I'm going to put you on the spot here straight away, Prasad, and say, for us, we want to be done away with random biopsy.
Vinay, can you hear me?
I can hear you, Prasad. Can you hear me at the moment? Okay, so while we're waiting to reconnect, Prasad, can you hear me? Great. So Prasad,
Yes.
I was just saying that for us really in the Barrett space, we are trying to move to a field where we're not taking random biopsies. Yeah, and for all the reasons that you illustrated earlier on in your talk. But it looks as if the data on Watts doesn't seem to say that we can do that just yet. And Matt and I were having a chat offline during your presentation, and we were thinking, do you think there's a role for targeted biopsy plus Watts 3D? What are your thoughts on that?
No, I think that's an excellent question. At least the data that we have so far seems to suggest that we yet can't give up the Seattle protocol biopsies. However, a trial to investigate this question that you raise, Watts plus targeted biopsies is actually going to start or may have already started in the United States, called SWOT-BE, and that's exactly the question that is going to be answered, where people will be randomized to, I believe, targeted biopsies plus Watts versus targeted biopsies plus the Seattle protocol. We'll just have to see what those results show. The challenge in my mind is that dysplasia seems to be randomly distributed throughout the Barrett segment. We are not as good in picking up visible abnormalities. Now, with artificial intelligence algorithms coming up, that might change the picture as well. We might just get that added boost to inspect carefully and not miss some of the quote unquote visible lesions that we are looking for all the time. So we have a number of possibilities coming up, but we are just not ready, I think, to give up Seattle protocol biopsies just yet.
Sure. Matt, I'll hand over to you.
Thanks, Prasad. Great talk, and clarifies a lot of the issues and the many questions asked about ongoing surveillance. But you've shown that surveillance actually contributes very little in view of the lack of adherence to the Seattle protocol, the missed lesions. But you really have to consider the cost of random biopsies, particularly for long segment Barrett's, and the time taken and distraction from spending the right amount of time inspecting mucosa using techniques such as acetic acid dye spray. And you could argue that perhaps, I know this is not evidence-based and the data is not there at the moment, that perhaps we should be focusing on detection techniques rather than continuing to blindly randomly sample the esophagus. And I suppose that's a point rather than the question. You've already answered it. And the second question is, particularly the advent of Cytosponge, where do you see the future of screening, given that Barrett surveillance has a minor impact on the prevalence of esophageal adenocarcinoma in the West?
Yeah, no, I think that's the billion-dollar question in my mind. As you know very well, we are focusing surveillance efforts on a small slice of the pie. The people who we know have Barrett's. We think, and I think there are several studies to suggest that most of the patients who have Barrett's are not under surveillance. So you could do the best surveillance possible on 20%, 30% of patients with Barrett's. You are not going to make an impact on a disease which we now think arises mostly from Barrett's. So a complementary strategy has to be to identify more or maybe most of the patients who are at risk for esophageal adenocarcinoma and place them under better surveillance. So I couldn't agree more. I think the United Kingdom, led by Dr. Fitzgerald, has led the world in terms of coming up with these strategies. We in the United States are also taking inspiration from this. You know, there are a couple products that we might get in relatively short order. One is commercially available. The other one is likely going to be close behind with Exact Sciences, also collaborating with Mayo Clinic. And I think some kind of minimally invasive screening technology is necessary, but we do need to combine that with more efficient surveillance. So we can't have a situation, I think, where we have more and more patients with Barrett's entering the same inefficient surveillance pipeline that we have now. So I think we have to work on both of these. And they are both complementary strategies in my mind.
Yeah, thanks, Prasad. And that actually leads on really nicely to a question which we've been asked by some of the viewers at home, really, talking about the capacity that we have and sort of a very finite endoscopic resource and the sort of the demand that we have to meet that resource. And Cytosponge is something that's been mentioned a couple of times already, and you alluded to it towards the end of your talk. So I think it's a nice lead in to the next lecture, which is actually delivered by myself, provided a real-world update on Cytosponge. So really discussing how we were able to utilize the Cytosponge during the height of the pandemic to rationalize our scarce endoscopic resource at a very difficult time, and actually help detect those high-risk patients who couldn't really wait for another endoscopy. So if we could move on to the next recorded lecture, and then we'll come back to you, Prasad, after that, okay?
Thank you.
Hello, my name is Vinay Thego. I'm a consultant gastroenterologist at University College Hospital in London. I'd like to begin by thanking Prasad for giving an excellent overview on tissue sampling methods in Barrett's. And in particular, my talk for the next 20 minutes will focus on the role of the Cytosponge device and provide a real-world update from our institution where we implemented the Cytosponge, in particular during the COVID pandemic, to rationalize surveillance endoscopy in those that were overdue procedures. These are my relevant disclosures. So as you have heard today, there is a very well described Barrett's to cancer sequence where there is replacement of normal stratified squamous epithelium of the esophagus with columnar type metaplastic tissue. This we think is caused by chronic gastroesophageal reflux disease. Although the vast majority of patients will not develop cancer, there is a significant proportion that will, and there is a stepwise change in dysplasia from low through to high-grade dysplasia in cancer, whereby which through each sequence your cancer risk increases. This is clinically relevant because Barrett's esophagus remains the only identifiable pre-malignant lesion for esophageal adenocarcinoma, the incidence of which has increased significantly in the Western world in the past 30 to 40 years. We are aware from large-scale studies looking at endoluminal clearance that if we can detect and treat Barrett's esophagus at an early stage, and by that I mean mucosal or superficial submucosal disease, the risk of lymph node metastases is negligible. However, when the disease is more deeply invading into the deep submucosal and muscularis, the risk of lymph node metastases increases exponentially, and in these patients, surgery or chemoradiotherapy is necessary. Despite a lack of randomized data, most societal organizations recommend periodic endoscopic surveillance with 4-quadrant Seattle protocol biopsies of the Barrett segment to look for early signs of dysplasia to help prioritize endoscopic surveillance and/or therapy. There are some significant drawbacks to this approach, including lack of tissue sampling in terms of only sampling 5% of the visible Barrett segment, and also inter-observer variability, in particular with low-grade dysplasia amongst pathologists. The Cytosponge is a well-tolerated non-endoscopic biopsy option for patients. It simply entails a capsule on a string which is swallowed by patients. Once the capsule enters the stomach, after a few minutes, it is gently retracted back through and takes a biopsy from the distal esophagus. There is good evidence to show that it is very well tolerated, and even better so compared to endoscopy without sedation. There is also qualitative data to demonstrate that the Cytosponge can reduce anxiety level amongst patients and is not inferior to endoscopic surveillance. There has already been a wealth of data looking at the Cytosponge device. In particular, in the UK, we have seen the BEST-1 study, which was a feasibility study looking at patients with symptomatic reflux disease. This was followed by the BEST-2 study, which was a case control study in patients with reflux disease and Barrett's. And the take-home message from all of these studies is that the Cytosponge was able to detect Barrett's esophagus with a sensitivity in excess of 80%, which neared 90% in those with longer segments of Barrett's. Overall, nearly 3,000 procedures have been performed worldwide, and the device is successfully swallowed by nearly 97% of patients, with only 2 adverse events in the literature reported, which is very encouraging on the whole. More recently, the BEST-3 study was a large-scale randomized study in which patients with symptomatic reflux disease requiring PPI were either randomized to standard of care, which would be PPI and endoscopy on demand, or the Cytosponge. This approach was found to have a 10-fold increased detection of Barrett's esophagus compared to controls. Numerous biomarkers have been studied for the Cytosponge, but those that have been most widely established include trephine factor 3 or TFF3, which is a marker of intestinal metaplasia. There have also been a wealth of molecular and cellular markers, but the two that we have focused upon in our work has been glandular atypia and P53 overexpression. This elegant study back in 2017 showed that a combination of these biomarkers could accurately predict a low-risk cohort of patients with Barrett's. This figure here really sets the scene for our work in the Cytosponge in a real-world setting. So we knew that during the pandemic, there was a significant reduction in endoscopic activity, meaning we had to rationalize our very scarce endoscopic resources at the time. Surveillance endoscopy fell by the wayside, and we therefore were left with a dilemma with how we rationalize endoscopic procedures for those patients in whom surveillance was overdue. Our idea was to use the Cytosponge that I will describe shortly to help mitigate against this. So we divided our cohort of Barrett's patients into those with no previous therapy, which formed the biggest arm, and these are patients that had either a less than 2 centimeter segment of Barrett's with intestinal metaplasia or more than 2 centimeters of Barrett's with confirmed biopsies in the past 5 years. And we also looked at a smaller group of patients that had previously completed endoscopic eradication therapy and given previous evidence were deemed low risk. So this included those that had no visible Barrett's at the last endoscopy or dysplasia, and those that were more than 18 months from completion of endoscopic eradication therapy. We followed the same protocols in terms of anticoagulation measures in those having a diagnostic endoscopy for simplicity's sake. Some important exclusion criteria included those patients with a history of dysphagia, those that had previous history of esophageal surgery, including a fundoplication, which we will get to later. So we developed a simple algorithm for these patients based upon molecular markers seen on the Cytosponge. The patients that had agreed to have the Cytosponge, we deemed them to have a high-risk result if they were positive for P53 and or atypia. In this group of patients, we offered an endoscopy within 3 months. In the other group of patients, in those that whom were TFF3 positive in isolation, but had no evidence of P53 or atypia positivity, their endoscopy was deferred for 12 months or 6 in the case of post-treatment patients. In those patients that were negative for all 3 markers, we questioned whether the sample had actually entered the stomach adequately. In the first instance, they were offered a repeat Cytosponge procedure. If they declined this, we would offer them an endoscopy when next available. These are the basic demographics of both treatment cohorts. So we performed the procedure and now have follow-up endoscopic data for 137 patients. The male to female ratio and age is expected given our understanding of this condition to date. Obviously, patients in the previous treatment cohort had no visible Barrett, so there was no relevant maximum length of Barrett's in this cohort, whereas it was 4 centimeters for the no previous treatment group. If we look at the no previous treatment group first, we had 2 patients who were unable to swallow the Cytosponge. 5 patients required a repeat Cytosponge, and importantly, we were unable to retrieve the Cytosponge in 2 of these patients. Fortunately, both of these were retrieved endoscopically. One was due to a history of cricopharyngeal spasm, and the other was in a patient in whom the Cytosponge had become trapped within the wrap, and it then became part of our exclusion criteria moving forwards. Both of these were managed endoscopically on the same day, and importantly, there was no serious adverse events, including sponge detachment, bleeding, or any other serious complications. So if we delve down into this group in a little bit more detail, so we have 110 patients in whom 24 patients had a high-risk result. We focused on here. So if we look at these patients, we can see that if we look at low and high-grade dysplasia, as well as intramucosal cancer, we can see that there were 7 new findings of low or high-grade dysplasia. The one cancer diagnosis was actually seen in a patient who was negative for TFF3 but had a positive p53 overexpression. If we also look at the other side in the low-risk cohort, there were 6 cases of either low or high-grade dysplasia. If we delve into this in further detail, we can see that in the 5 patients that had low-grade dysplasia, 4 of these patients previously had historical biopsy evidence of low-grade dysplasia. And in the one new case of high-grade dysplasia, which was a true high-grade dysplasia, this patient had a long segment of Barrett's with a positive family history for esophageal adenocarcinoma, which raises the question as to whether these factors should be incorporated into our decision-making tool. Therefore, nearly a quarter of patients had new endoscopic or biopsy-proven dysplasia, with one new diagnosis of high-grade dysplasia. Interestingly, p53 overexpression was seen in all cases of dysplasia or cancer in this group of patients. This is an example of a case. This was a 67-year-old gentleman with an 8-centimeter segment of circumferential Barrett's, who was previously having 2 yearly endoscopic surveillance with no previous history of dysplasia. He had a visible lesion seen at endoscopy with loss of aceto whitening, which was removed by endoscopic mucosal resection, uneventfully, the histology of which confirmed high-grade dysplasia, and he has subsequently gone on to receive ablation of his residual Barrett's. In the previous treatment cohort, 5 patients were excluded from follow-up analysis. So 2 of them still have an endoscopy pending. 1 patient was unable to swallow the cytosponge, and 1 patient passed away prior to their endoscopy being performed. So overall, we had 27 patients in whom there was a high-risk result in 1 patient who went on and had high-grade dysplasia. In the remaining 26 patients, there was no evidence of low-grade, high-grade dysplasia or cancer. There were a few foci of indefinite for dysplasia, none of which have required endoscopic therapy. And what needs further investigation is looking into the patients that had intestinal metaplasia. Was this merely intestinal metaplasia of the cardia, or was this recurrence of Barrett's? There's a lot of work going into this with recent publications looking at the clinical relevance of this finding and whether we should be biopsying in the cardia or not, and that will be a topic for debate moving forwards. So in our gentleman with a high-risk result, this was an 87-year-old male who'd had previous multimodal endoscopic therapy with endoscopic mucosal resection followed by RFA for high-grade dysplasia back in 2014. His last endoscopy prior to the cytosponge was in August 2019, where he had no residual Barrett's and biopsies containing no intestinal metaplasia or dysplasia. His cytosponge was positive for TFF3 and p53, but negative for atypia. At endoscopy, he was found to have a nodule in the cardia with a distorted surface pattern, which was removed by a single EMR, the histology of which confirmed high-grade dysplasia with a clear, deep resection margin. This raises a further issue regarding the need for ongoing endoscopic surveillance even after completion of therapy, and we know that this is the case from literature to date. This is one of the seminal papers looking at the cytosponge in patients that have been treated for Barrett's with dysplasia, and it found that the cytosponge was comparable to endoscopic surveillance in terms of mortality related to esophageal adenocarcinoma, and if anything was more cost effective than endoscopy. However, one limitation of this approach was that 1/3 of patients that had completed eradication therapy were unable to swallow the cytosponge, which limited its uptake. In our study, we've seen a significantly lower proportion than this, and perhaps this opens the gateway for further work in this field. This was a more recent publication by Rebecca Fitzgerald's group in Cambridge, in which they developed a real risk stratification tool which coupled biomarkers on the cytosponge with clinical risk factors, including Barrett's segment length, male gender and age, to help prioritize the needs for endoscopy. So essentially, in patients that had a biomarker negative cytosponge, they were further subdivided into a low or medium risk cohort. They first applied this tool to retrospective data from BEST 1 and 2, and they found that this tool was able to detect patients with high-grade dysplasia or cancer with a sensitivity of 94%. They then validated this further in a prospective cohort of 223 patients and found that it was very accurate for detecting high-grade dysplasia or cancer, and perhaps this shall be the approach that will be needed moving forwards. Cost is important, and we know that in the UK, the cost of an endoscopy is not insignificant. So when we add up the cost for an endoscopy, followed by each level of biopsies, which on average are 3 separate pots, and then the cost of your operator personnel and sedation, that is significantly in excess of that of the cytosponge, which can be performed outside of an endoscopy unit. It doesn't require sedation, and it can be performed by a healthcare professional that need not be a nurse or a doctor. There are lots of future exciting avenues on the horizon. One of these is the Delta project, which will be an algorithm which will be incorporated into primary care in the UK, which will highlight patients that are at risk of esophageal adenocarcinoma based upon chronic prescriptions of PPIs for heartburn. These patients will be offered a cytosponge followed by an endoscopy if appropriate. All of this data will be fed into a digital pathology and AI machine, which will allow high throughput of results, and perhaps it will change how we manage these patients, or particularly investigate them moving forwards and help rationalize endoscopic resources. There was also a little bit of data that has come out showing that the cytosponge may also be able to detect early pre-malignant change of the stomach. So investigators from Cambridge analyzed data from the BEST3, and they saw that patients that were positive for TFF3 but had no endoscopic or histological evidence of Barrett's, a third of these patients actually had intestinal metaplasia and gastric atrophy, and perhaps therefore this tool could also be looked to investigate pre-malignant changes of the stomach, which is of increasing interest. So future developments that are now on the horizon. So NHS Scotland has really moved towards a cytosponge favoured approach. So all patients that are due endoscopic surveillance are instead offered the cytosponge first line. And this is also the case for patients with chronic reflux disease without risk factors, in whom they are triaged straight to cytosponge instead of endoscopy. Finally, we'll be hearing more from the Cambridge group and the BEST4 study, which will be a very ambitious project investigating more than 120,000 patients, of whom 40,000 will have the cytosponge, to really assess the long-term benefits, including mortality, as well as opening the gateway to potential screening for patients with Barrett's. So this is a very ripe field of interest, and we continue to read with interest results as they are available. Thank you for your time. I will now head back to the recording studio.
Well, thank you, Vinny. That was a really interesting talk. I've got a question for both of you, which is, based on the data that we've just seen, the miss rate in those 371 patients with low-risk cytosponge was about 2%. And Prasad, you've already shown some data suggesting that the miss rate of prevalent cancer is up to a third. So already we're seeing that cytosponge may well be outperforming endoscopy. So if you consider the other factors, it's half the price of endoscopy. It is possibly easier for the patient if it can be performed in a community setting, and it's a lot more eco-friendly because the processing, you don't use the cleaning chemicals, etc. for endoscopy. Why is this not the preferred test now for surveillance and Barrett's? Prasad, would you like to answer first?
Yeah, I think that's a very provocative question in my mind. I think we need some more consistent data, Matthew, I think in my mind to show this. I think the trends are there, but for us to make a practice change, I think this data would have to be confirmed, replicated, and shown consistently across, other studies. Remember, the data on surveillance came from a large systematic review and meta-analysis of thousands of patients. So I think this is something that has a lot of legs, but we need to keep studying it. And I suspect the economics are probably going to be easier to show. We just have to see what is the miss rate in Cytosponge versus endoscopy in larger studies. I think we leave it at that, but this is obviously going to be a big part of subsequent studies in the field, in my mind.
Yeah, I agree. Vinny, based on your experience with the post-COVID or the COVID study, what's your view?
I think there's real traction in this. I think it's, for the reasons you've outlined, it's a very attractive alternative to endoscopy, and I think this has got legs to grow, to be honest with you. I think we did see one case of a negative cytosponge in a patient who had high-grade dysplasia. Interestingly, this was a patient that had a family history of esophageal cancer and was a relatively young gentleman. And that leads in nicely to the medium risk cohort, which the Cambridge group have identified. And I think if we were to use the cytosponge instead of endoscopy, we need to be vigilant of that cohort. So it's not a one size fits all. I think that's the first thing. I think one thing we haven't really spoken about is patient acceptability and tolerance. Are those patients that are already on endoscopic surveillance programs, will they be happy to have a cytosponge instead of endoscopy? I'm not sure what the answer to that question is. I think the new incident Barrett's patients, if they've not had an endoscopy before, would probably be rather accepting of regular cytosponge. But I'd like to know a bit more about what patients think about having a cytosponge when they've been used to having an endoscopy every 1 or 2 years. That's an interesting aspect to it. And probably that's going to be a physician-led kind of conversation. You can direct patients, generally speaking, but I think that needs a little bit more work. And there is a big training arm to this. This is not something at the moment that patients can do themselves. I think this does require nurse training, but it's relatively simple to do. It's a much shorter learning curve than learning endoscopy, for instance. So I think these are questions that will need to be answered. I think the BEST 4 study, as I talked about at the end of my presentation, will answer some of these questions moving forwards, I think. And I think it's a ripe topic for growth, I think. And I think we may well get to a point, I think, where we will be doing less Barrett surveillance endoscopy, which I think is a good thing.
That's really interesting.
I think the other, just another point I would maybe want to raise, I think these are all excellent points. Safety to me is also an important thing, right? So, looking at your data, Vinay, that you just presented, there were at least 2 patients where the cytosponge couldn't be pulled out. And, that was in under 200 patients. It is potentially, I think we have to remain aware of that possibility. Does that mean emergency endoscopy has to be available in all of these patients? We talk about using the cytosponge as a replacement, but in those instances where it doesn't come out, small numbers now, but if you apply this to a large population, that number can grow. How do you handle that? So I think those are some of the issues that we also need to wrestle with, in addition to the others that you've already highlighted.
Thank you, Prasad. I was just going to say, along those lines of patient acceptability and risk, safety, obviously these studies need to be undertaken. But it is interesting, if you look at patient outcome reported measures and PREM studies in endoscopy, there aren't that many. But in terms of patient attitudes and expectations, they want the best quality procedure, and they don't mind a little bit of extra discomfort, providing they have good outcomes. Exactly. I think we need to combine with these types of studies, we need to combine a PREM element when you're doing large population studies as well.
I think that's very critical in my mind. And, populations can be somewhat different as well. I think the degree to which discomfort can be tolerated varies across the world as well, as you very well know. So I think that might be another issue that is unique to different populations.
And I think one final thing is we are obviously dealing with an increasing cohort of post-therapy patients that we're bringing back again for repeated endoscopies, and our own internal data seem to suggest that the sponge was more reliable in terms of tissue sampling than previous studies had suggested, where 30% of sponges had to be repeated. So that's another area where the sponge may play a real role, and it will be interesting to see how things develop. So Prasad, we're going to be moving on, so I'd just like to thank you ever so much again for taking the time out to join us this afternoon.
Thank you so much.
Great to see you. Yeah, great to see you, and look forward to seeing you in London soon.
Thank you, Prasad.
Absolutely. Thank you. Bye.
Thanks. So we're going to now move on to the next session, which is really an interesting session for me because we're going to be exploring challenges in endoscopic therapy and endoscopic eradication therapy, which is something we get asked a lot when we go around. How do you deal with this? How do you deal with that? And we've put together a selection of challenges that we think are relevant to endoscopists doing therapy. And I'd like to, at this juncture, introduce Dr. Jose Miguel. He's a professor of gastroenterology from Madrid and a very good friend. Jose Miguel, are you there?
Me?
We'll just wait for him to dial up. There we go.
Hi, how are you?
We're good. Thank you for joining us. How are you?
Thank you for your invitation for this fantastic course.
Oh, so it's a pleasure to have you here again. So I'm here with Matthew Banks in London, and we're going to be talking about challenges in endoscopic therapy. And I know something quite close to your heart is squamous dysplasia. So what we're going to do at this stage is go straight to your lecture, Jose Miguel, looking at how we can improve our detection of esophageal squamous cell neoplasia. And then we'll join you back again for a question and answer session thereafter.
Okay, perfect.
Great. So can we please go to the presentation?
Good afternoon, and thank you very much to Dr. Rehan Hedri and all the team for your kind invitation. And my topic today is just how to improve the endoscopic detection and characterization of esophageal squamous cancer. So what can we say about this? We need to remember that in some areas of China, Northern Ireland, and Central Asia, this is the most important esophageal cancer. In this area, more than 90% of the esophageal cancer are squamous cell carcinoma. You can see that in China, the number of cases per year are more than 200,000 cases. And in England, in the UK, the annual cases are just 4,500. But we need to know that this cancer will increase in the following years, in the next years in this area. So there is like the esophageal squamous cancer belt, all these dark blue area, and as you can see in Europe, there are areas that the rate is very, very low. But globally is the 7th most frequently cancer in the world. And early detection is really difficult. As you can see, the only tool that we can have for early detection is the appearance of the symptoms, the appearance of dysphagia. So as you can see, if it is dysphagia, the cancer is advanced. So we don't have really tools to detect early this cancer. And we need to know that who are the patients that they will develop this kind of cancer. We need to think that those patients with any kind of head and neck cancer or dysplasia, they will have more frequently this kind of a squamous cancer. And like as we do in other endoscopic pathologies, we need to think how can we improve the management of this pathology. You know, in this case, the squamous cancer, esophageal squamous cancer. How can we improve endoscopically? We can improve the endoscopic exam. This is crucial, as we will see. We can improve also the endoscopic tools that we are using, and apart, we will get better therapeutic options endoscopically for this pathology. So, the endoscopist, how can we improve the endoscopic examination? The endoscopist is the most dependent part for this. And as I always says to my fellows, the esophagus is the easiest part of the study of the upper GI tract and also the colon, because after you pass through the upper esophageal sphincter, you go straight. And if you don't pay attention, even when you introduce the endoscope or in the pullback endoscope, you won't see many of these dysplasias in this kind of cancer. So you have to take care and pay attention in the esophagus. And what we will use, the most important thing for screening and surveillance is to use a good endoscope with post-processing with high definition, and also post-processing virtual chromondoscopy. But the dye-based chromondoscopy will be very important in this kind of patients. Chromondoscopy involves the topical application of stents or pigments to improve tissue localization, characterization, or diagnosis during endoscopy. There is an important interest that it's increased with the development of technologies such as the EMR, ESD, RFA, or photodynamic therapy that requires precise visual tissue characterization, and it's been used in conjunction with other advanced endoscopic imaging such as magnification endoscopy. The advantages are that the equipment needed for endoscopy is widely available, and the technique is simple, quick, inexpensive, and safe. Which are the disadvantages of this, or limitations? It is time consuming, but most of the studies are needs time. It is quite messy with risk mainly of aspiration of the content. It is not clear if it is really carcinogenic, and the appearances, as in all these studies, are a kind of subjective, and the staining is widely inconsistent. So about the vital stains absorptive, the one we will use for esophageal cancer, squamous esophageal cancer, is the Lugol. And you can see these images. It was taken several time ago, but we'll see those areas that the stain it is not like in this area, is the suspicious area of dysplasia. We will apply it in Lugol solution in 1 or 2% of Lugol solution. And you can see these kind of images after applying Lugol solution. It will be the suspicious area is this one. And you will see in this one that you can apply very real the area. With Lugol, you can identify the suspicious areas of dysplasia where you have to take biopsies. There are some side effects like allergy, burning sensation, esophageal spasm. It goes thinner, the caliber after applying Lugol in some cases, and it can cause also some kind of allergenal edema. There is an antidote for this, and this is an old video taken in my unit where you can identify all the suspicious areas of dysplasia where you have to take biopsies. And as you will see after with the vascular identification of the dysplasia, you will take more attention of that area. And what about the squamous epithelium? In some cases, as you can see in the video we have seen previously, there are not a really surface structural alteration in this, and you can have you also can have some kind of submucosal cancer. So you have to take care and pay attention to all changes in superficial vascular structure. This is the most important thing you have to see in the endoscopic examination of the squamous neoplasia. So this is a difficult case where sometimes you don't really see any abnormality, but after playing a Lugal, you will see this. And there are some papers regarding virtual chromendoscopy applying in this to suggest it can improve endoscopic detection of esophageal squamous cancer with the Pentax system using iScan OE, and also with NBI in Olympus and BLI in Fujifilm. So we need to determine the invasion depth of this pathology. We'll see the morphology using wide-eye endoscopy. We can apply virtual chromendoscopy, BLI, iScan, or NBI, and we'll use a magnified endoscopy to determine the IPCL vessels to detect the invasion depth. So in morphology, there is a very old classifications, Paris classifications, and if it is just Paris 2A or 2B, the invasive cancer is very low risk, but in the other cases, 1 and 2C or 3, it will be for sure that the submucosal invasion cancer, it is very frequently. So, but this is not new. This paper is published in 1997, and where the ones that there won't be submucosal invasion will be 2B, 2A, that the chance it is very low. So with the NBI, you will see the vessels of this mucosa and the patterns of the patterns that they will detect irregularity, and you will see the dysplastic areas. But the most important thing will be the magnified endoscopic features. Like this, you will see normal microvessels in the normal squamous epithelium, but also some areas with brownish area and then normal microvessels, brownish epithelium intervascular. Like in this NBI imaging, that you will see this abnormal microvessels that will go deeper right now. So you will see in the IPCL changes in dilation, irregularity, in terms of dilation, weaving, caliber change, and shape variation regarding the normal vessels like this. And depending on the vessels, you will presume if the affection is deeper or not, just within inflammation. And depending on how it goes to deeper affection with large microvessels, you will determine that the carcinoma goes deeper. And why this? Because depending on this, there will be a vascular change with the modified IPCLs with some grades of irregularity in low grade, high grade, or mucosal cancer M1 or M2. But if there is a vascular change, the affection will be deeper, M3 or submucosal. Look here that we'll see the type of vessels A and B1. A, it will be normal or also in some low-grade dysplasia. B1 in in low-grade, high-grade dysplasia, and also in some cases of cancer, but M1 or M2. B2, it goes deeper, muscularis mucosa or SM1, and with it is B3 with thickening and high dilated vessels, and with different caliber, it goes deeper at SM2. You will see here the examples. Normal type 1, that it goes type 1 in M1 or M2, it will be like this. In type 1A, when there is vessels with loop formations, which is a B2, like you can see here, the lesion goes deeper in M2 or muscularis and M2. When it goes B2 vessels, it will go like this without loop formation. These thickened vessels without loop formations. I will go back to check and to see how it was the loop formation, that it's this kind of vessels with loops. But if you go deeper and it goes without loop formation, you can assume that it goes to muscularis mucosa, T1A muscularis mucosa or SM1. And when there is neovasals like this, like you can see here, it's the type B3 with severe irregular thick vessels. It will go deeper to SM2 or deeper, like you will see here. So this vasculature will remain, and we will see how deep goes the neoplasia. We can predict the depth of the infiltration regarding these kind of vessels. There is a paper published in 2017 comparing using this and using NBI. The sensitivity goes through, and for B1 71%, specificity of 100%, B2 94 with a specificity of 73, and B3 sensitivity of 75 and specificity of 97. And just the last will be the artificial intelligence. So this is being published in post-processing imaging of artificial intelligence in this year in 2022. And as you can see, the combined accuracy of artificial intelligence was 91% and achieved better performance than endoscopies in predicting IPCL subtypes and invasion depth, especially using for junior endoscopists. They have an invasion, IPCL subtypes and invasion depths were significantly improved with the artificial intelligence systems. And although there was not significant difference, this was published in China, the performance of the senior endoscopy was slightly elevated using this. So we will use also this in the near future. So this is a video of Rehan Heydari, and as you will see, taking some using OE, iScan OE, will check this big lesion if it can be treated or not. Depending, is a 2A to B lesion, and we need to detect the infiltration depending of the vessels, the IPCLs. So we need to take time. We will see the loop formation of the B1, and there are some cases that with the loop formations, the IPC, the A, B1 are here, these ones, but you will start to see neovasals like here. So this, with the new neovasals, it will change and the strategy, and maybe in this case that won't be treated because the chance of being SM3 it will be higher. Here the vessels are just B1, We haven't seen B3, but there are some dilations in some places that, as you will see, will think like here that maybe maybe the infiltration is deeper. Dr. Heidri can do a comment of this. So now we won't see any dilation or neovasals different than B2 or B1, and we will decide if it went deeper. I think this is B2. So to take home messages, we will need to remind that squamous esophageal cancer is difficult to detect. As endoscopists, we need to spend more time in identifying suspicious areas. We need some tools. It's mandatory to have high definition, advanced imaging systems like BLI, NBI, and iScan OE, and Zoom endoscopy. The vascular pattern and IPCL's abnormality will help to identify which lesions will need surgery and which others just EMR or ESD. And artificial intelligence will become commonplace. So thank you very much, and special thanks to my colleague and my friend Rehan Heidri, creator of most of the images, videos, and slides of this presentation. Thank you.
Great. Thank you, Miguel, for a fantastic lecture and a really, really clear explanation of how to interpret IPCLs. I'd like to introduce Rami Swice, a colleague of mine and friend at UCH, who's joining us for this session.
Then I think it'll be like...
quick question for you. As the definition of endoscopes improves, we've seen data.
But you don't have. But do you have to be there with them?
The accuracy, sensitivity, and specificity of electronic chrome endoscopy is as accurate as Lugol's iodine, which, as you've explained, does have some drawbacks in terms of allergy, pneumonitis. What are your thoughts on doing away with Lugol's for the detection of squamous neoplasia, number one? And number two, would you suggest everyone on retraction of their endoscope to switch on MBI or iScan or FICE because the definition of squamous neoplasia is so apparent when you change the frequency of light and processing?
Okay, thank you for the question. I think one important thing regarding squamous dysplasia in esophagus, as I said in the presentation, it's very easy to introduce the endoscope after the upper esophageal sphincter. You go straight on, just looking for the cardia. So maybe in most cases we have seen some difficult dysplastic or suspicious dysplastic areas that we don't see. So I would recommend to use Lugol just in 1% of concentration, no more. And in those cases with head and neck cancer, it helps for screening in this group of patients that they can have some dysplastic areas in the esophagus. And if not, I think it's mandatory to the pullback endoscope of the esophagus from the cardia, not only for Barrett's, also for the whole esophagus. And with high definition and with NBI, optical enhancement or whatever of this, I think can be enough. I'm not using Lugol. I'm just using this for selected cases when we need to check in high-risk patients dysplastic areas right now.
Thank you. And Rami.
Thank you, Jose Miguel. That's fantastic talk. It's really, really informative and helpful. Great to see you from a distance. Can I just shift towards therapy? When treating patients with squamous dysplasia, we find sometimes, or do you find that after therapy, EMR or ESD, that they're perhaps more at risk of complications such as stricture formation or perforation compared to patients who have therapy in the columnar mucosa within Barrett?
Yeah, thank you for the question. In my opinion, in Europe, we don't have many cases of this type of cancers. It's difficult to delineate the areas we need to resect. Most of the cases needs ESD, and the chance of being with some kinds of complications are higher. I think that depending on how it goes, this condition, this kind of cancer in the future, we will have more experience, or we need to have some very important, very specialized areas more than in Barrett's, because if not, the chance of complications in this will be higher. Depending on this, the problem also, as you know, also is that you are resected one area, but the condition of squamous dysplasia can reappear in other areas of the esophagus. So it's a difficult topic, a difficult question, and I don't know how can I do, or how can we treat this with less rate of complications. In my opinion, just having a huge experience in a small in a group for a big group of patients, or area of patients.
Thank you, Jose Miguel. Well, that brings us on to the next talk, which is management of endoscopic related stricturing.
Thank you very much. Thank you.
Strictures in esophageal endoscopic therapy, both prevention and treatment. These are my declarations. So I'll include those who are at risk of the iatrogenic strictures, both after EMR, ESD, and radiofrequency ablation. How to prevent strictures in those who are at highest risk, definition of different types of strictures, and once established, what forms of therapy we can offer patients and how effective they are. So the UK guidelines written by Sami Samed outline both the general approach to esophageal strictures as well as disease-specific management, including endoscopic therapy. So it's definitely worth a read. So the risk of strictures is really dependent upon how extensive the resection is. Overall, the stricture rate is between 5 and 17%. However, once the resection reaches 70% of the esophageal circumference, the stricture rate can increase up to 90%. And in those who have a complete circumferential resection, the stricture rate nearly always reaches 100%. Other factors that can increase the risk include the extent of the cancer invasion, particularly if it's beyond M2, the length of the stricture, so those who have, the length of resection, those who have resections over 30 millimeters. And finally, strictures are far more common for proximal resections versus distal resections. And once established, most of the strictures tend to be moderate to severe. And development of strictures is between 12 and 60 days. So if you are thinking of bringing a patient back for dilatation, these are the timeframes to consider. So one way of thinking of stricture prevention is in terms of mechanical devices such as balloon dilatation or self-expanding metal stents, anti-proliferative measures, including steroids, as well as avoiding acid exposure, so maximizing PPI therapy. And more recent developments are utilization of tissue engineering techniques using polyglycolic acid, or PGA. So starting with endoscopic balloon dilatation, most studies have suggested that you start between 3 and 7 days after a section, and then undertake weekly dilatations up to 8 weeks. The starting and finishing diameter suggested for each dilatation session is between 13 and 15 millimeters. And on the whole, most people, or most patients achieve reasonable response with a median of 4 dilatations, although more complex strictures may take up to 20 dilatations. With this technique, however, the rate of perforation is as high as 9% in the more complex strictures, and you need to obviously make the patient aware of this before you set about this technique. Now, steroids can either be used orally or injected, and there are a number of studies showing benefit for injected steroids. Now, it's really important, in fact, it's essential that you avoid injecting into the muscle, because that will set up further inflammatory response and may make the stricture worse. Use the 40 milligram vials of triamcinolone, and with a dilution of 10 milligrams per mil. The injection should be started with a small 0.2 mil aliquot at the proximal end of the resection base, and then further aliquots injected 1 centimeter apart, starting circumferentially and then extending distally. Advice is to do the first one on day 3, second on day 7, and then the third 10 days post ESD. Now, if you have a look at some of these earlier studies, the incidence of stricture after injected triamcinolone reduced from 75% in the control group through to 19% in the treatment group. Also, the number of balloon dilatations significantly reduced from 6 to 1.7. In a more recent study with Takahashi, the benefit was a little bit more conservative, but there's still benefit, and the number of dilatations required was then halved. Now, if you look at oral steroids, the protocol here being 30 milligrams of oral prednisolone per day, tapered over 8 weeks, there's also a substantial improvement in stricture formation, comparing controls and patients, from 30 to 5%. And also the mean number of balloon dilatations also reduced significantly from 15 to 2%, not just under 2%. Now, a more recent meta-analysis with both injected and oral steroids showed overall there was a 60% reduction in stricture formation, and a slight superiority of injected steroids over the number of balloon dilatations. These are the PGA sheets, the polyglycolic acid sheets that I mentioned before, which are glued into the wall of the resection base at the time of the ESD or once it's complete. And the results are really very promising. Only 1 out of 13 patients develop strictures. However, they have to be glued in with fibrin glue. They're quite tricky, they're quite expensive, and they're not available, but certainly there's a significant promise. Finally, the final technique for mechanical prevention of strictures is the use of self-expanding metal stents. And this study by Weng, 2014, showed, as you can see, quite substantial improvement in stricture rate from 74 to 18% and reduction in dilatations. However, and these were in patients who had high risk of stricture formation with either 75 to 100% of the circumference in terms of the ESD resection. However, there's at least a 20% migration rate. A lot of the patients had pain after the stent, so it's not ideal, and it has to be removed within 8 weeks. So once patients established a stricture, you have to consider a treatment algorithm, bearing in mind that most patients do establish normal eating patterns after 3 to 4 dilatations, with a reasonably low perforation rate of 0.3%. However, in those who have more complex strictures, the results are likely to be refractory to initial dilatation. And complex strictures are defined as those that are regular, angulated, at least 2 centimeters, often multiple, and they're more common with post-radiotherapy, caustic stricture, or endoscopic therapy. In these strictures, I'd recommend that they have sequential balloon dilatations before considering anything else. But the definition of a benign refractory stricture is the inability to maintain a luminal diameter of 40 millimeters after 5 sequential dilatations, 1 to 2 weeks apart, or maintain a target diameter for 4 weeks once it's been reached. Now, this is the algorithm I'd suggest. Once the initial dilatations have failed, initially consider weekly dilatation for 6 to 8 weeks. Now, if this doesn't work, then consider intralesional steroids, followed by incisional therapy, and either self-dilatation or self-expanding metal stent, depending on what you've got available in the department, and the last case scenario is surgery. So general hints or guidance with regard to balloon or bougie dilatation is always use CO2. Consider initial dilatation of between 10 and 12 millimeters, or if there's a really severe stricture, try to limit it to 9 or less. Although there's no evidence to support the rule of threes, I'd suggest each session you should dilate in 3 increments between 1 and 2 millimeters apart, and then don't go beyond that unless you really feel confident. So there will be slightly increased risk of perforation, and it's much safer then to bring the patient back a week or 2 later. And always use fluoroscopy if using bougies, if they're complex strictures, large hiatus hernia, diverticularly, or it's a really tight stricture and you can't see through it. There's no difference between balloon and bougie, certainly from the data. However, I prefer to use a balloon for fairly short strictures, if there's no fluoroscopy available as well. And then I usually reserve bougie for more complex strictures. The protocol for triamcinolone injection for recalcitrant strictures is to use 40 milligrams again, the dilution of 10 milligrams per mil, and just inject 1 mil into each quadrant. Again, try not to inject into the muscle, so that'll cause trauma and may exacerbate the stricture. Most of the data for post-dilatation steroid injections was established with peptide strictures, showing there's a reduction both in the need for dilatation and also increases the dilatation interval. There's no data for post-endotherapy strictures, and the data for caustic and anastomotic strictures didn't show any benefit. Incisional therapy is very satisfying because the patients often experience quite a significant improvement in symptoms immediately after the procedure. It has to be undertaken carefully, however, and if you have any experience with ESD and EMR, then the techniques or Zenker's diverticulotomy, the techniques are very simple and similar. My favorite knife is an Olympus IT2 with a porcelain insulated tip. The top of the tip, there is some conduction, so you can still cut by pulling. The IT Nano, on the other hand, is slightly smaller, and the insulated tip is completely insulated, so there's no cutting on the top of the porcelain. After each cut, I'd inspect the base and try to cut towards the greater scar. So if you can see in these images on the top right, you can see quite a substantial scar. This is in fact an anastomotic stricture. You can see a substantial scar where the blue arrows are. So the direction of cut should be towards this scar, so it's the greatest density of fibrotic tissue. And you can see Each cut, you pull the knife slightly back so you don't push down, and that'll help you control the cut so you don't go too deep. And it's quite difficult often to tell the difference between scar tissue and muscle, but you can start to cut gently into the muscle as long as it's not too deep. If you do see what you consider to be a small perforation, then you can quite easily put a clip perpendicularly to the cut, as you would do with the Zenker's diverticulum in the base, and that should be sufficient. You can bring the patient back for recurrent sessions. If the stricture is any longer than 1 centimeter or 15 millimeters, then you can't really do incisional therapy. And finally, if the incisional therapy fails or the stricture is too long and complex to use incisional therapy, then consider a self-expanding metal stent. In a large pooled study, the clinical success rate overall was 40%, but with a reasonably high migration rate again of 26%. Unfortunately, once the stents are removed within 4 to 8 weeks, avoiding embedment, there's a recurrence rate of up to 70%, and then you may need to place more stents. There's very little evidence to suggest biodegradable stents are more superior than self-expanding metal stents, but of course, as I said before, they don't need to be removed, but be careful, they can cause pain. So in summary, the risk of strictures in patients having endoscopic therapy is very much dependent upon the extent of resection, with risk between 5 and 17% overall with EMR and ESD, and the risk with ablation is about 6 to 7%. So in those who are considered to be high risk, i.e. those with greater than 75% circumferential resection, consider a form of prevention, including intralesional or oral steroids, or self-expanding metal stents. Once established, most strictures do respond to the initial 3 dilatations, but the refractory strictures may require more complex and prolonged procedures, including either repeat dilatations, intralesional steroids, self-expanding metal stents, self-dilatation, or
That's very, very clear. Thank you so much, Matt, for this very clear talk, and always useful and informative. Can I ask, with regards to making decisions in advance of performing the procedures, do you consent to ask patients for their consent with regards to the potential complications that might occur and the risks of stricture formation post-ESD, for example, with a view to considering prophylactically treating them with a stent or what have you?
Yeah, it's a very good question, Remy. We obviously have a duty of care to the patient to fully inform them prior to consent. And we know that most patients where you're resecting more than 75% of the lumen, as we've discussed, they're going to end up with a symptomatic stricture. And some of these are long and refractory, and a patient who presents without symptoms and incidentally picked up the squamous cell carcinoma and can swallow perfectly well, you may render them dysphagic for life. So it's very important to say we're going to resect 100% of the lumen, you're going to get a stricture and it's going to be symptomatic. And these are the measures which we're going to take in order to improve the outcomes. And I think we have to be very clear that in addition to perforation and bleeding and the other possible complications, that they may be self-dilating, they may have weekly dilatations for many months. So you have to not only explain what the complications are, but how they're going to be managed and what they would expect.
we've had some experiences with biodegradable stents as well. What are your views on using those as opposed to fully covered metal stents when providing therapy?
Well, the advantage, of course, is once you put them in, you then don't have to remove them. And we know from some of the randomized studies which we were involved in with a range of different types of strictures, that they certainly reduce the number of dilatations required in those with refractory strictures, for example. But in our own experience, we found a lot of them to be very painful. And once they're deployed, and once they've been in for more than a few days, removing them, even removing them after they've been put in immediately, is very difficult because they tend to fall apart. So if someone develops severe chest pain, that may continue for weeks or months afterwards. And it's a bit idiosyncratic. We had a patient who did very well with the first BD stent, biodegradable stent. The subsequent stent induced severe chest pain, intractable vomiting, and they had to be put on to PN for a period of time until things settled down. So they can be very useful and very effective, but you have to be aware that they do induce pain, and they're not permanent either, because they may induce their own inflammatory response, which then leads to further scarring and stricturing.
How long do you keep a stent in after putting it in prophylactically to reduce the likelihood of stricture?
Yeah, that's a really interesting question. So the self-expanding metal stents, usually try to remove them within 8 to 10 weeks. If you leave them much beyond that, then they'll embed. Of course, you can always put a bigger stent in stent, and then you get pressure necrosis, and you can take both stents out at the same time. Going back to the stricturotomy that I talked about in the lecture, I thought we'd just show a case and talk through it.
Yeah.
So this is.
Ladies and gents, you would have heard the history of this patient. He has 2 esophageal pathologies. He's got a big hiatal hernia, above which he has a complex peptic stricture, which you can see here, and this has just been dilated by bouginage under fluoroscopy. This is the first of the etiologies. His second, more chronic pathology is this here, which is a simple stricture, but this is caused by previous tracheoesophageal fistula repair at birth. And interestingly, although he has got symptoms of regurgitation and reflux, this proximal dysphagia is what causes him the most symptoms. So we dilated him with a 16mm bougie, and this has been previously dilated with a balloon, and he's had very little symptomatic relief. So what we're going to do today is actually try something slightly different, which is something called a stricturotomy. So these fibrotic, simple strictures where there's almost a ridge will not respond to mechanical dilation with balloons, and actually because there's fibrous scar tissue there, what you want to do is to actually cut away that scar with a needle knife. So what I'm going to do here is I've got a conical cap on here just to help stabilize the distal tip of my endoscope. Knife out, please. I've got the IT nano knife here made by Olympus Endosurgery. And what we're going to do is basically like one would do for an ESP or a poem making mucosotomy, just cut away this ridge and expose the needle fibers. And again, just using a circular motion to let the scope do the work, not the knife. Just use it as an anchor to just get under that ridge and remove it and expose the underlying muscle fibers. There we go. So you can see just how fibrosing it is there, that even with that first incision, we're still not seeing muscle. So I know I'm safe here because I've got an insulated tip, and we're just going to use that same circular motion again just to get a little bit of depth, and then just slide under that mucosal bridge to carry out a circumferential, almost like a mucosotomy you would do for ESD. Some people will ask, do you need a pre-injection with this? Not really, because you want to try and get down to that sort of connective tissue layer. So here I'm just going to push the knife out a little bit more, you can begin to see the circular muscle fiber, the longitudinal muscle fibers beginning to appear, which is exactly what we want. And what I want to do is obliterate this ridge completely. It's going to come here from north to south. You can already begin to see just how difficult it can be to get all the way down. So needle out, yes, thanks. Go in the opposite direction here and remove this ridge. So I'm using here the Myo3 and Endocut Q on effect 1 to get quite a swift current because you don't want any delayed transmitted heat, and then you can begin to see the muscle beginning to appear underneath. Just there. Right, let's see how we're doing here. So we've got plenty of work to do here, so you can see that ridge is now gone. This lumen is now one with the esophagus, but on the posterior wall there's still a bit of work to do, so we can still go a bit deeper here, because you can see almost like a little cliff edge in the distant, just distant to the stricture. You can see where the true esophageal lumen is, and that's what I'm aiming for. So I'm just trying to disrupt this ridge, see if I can get a bit deeper. Now you can see I'm beginning to expose the muscle fibers, so you have to just be that a little bit more careful here not to go too deep and cause a transmural defect. You can see I'm still shaving off quite a lot of tissue here, and it's coming together. So already you can see here we've managed to recanalize quite a lot of the esophagus, but there's still, what I do is I don't go and do the 360 stricturotomy in the first go, because actually that can have a counter effect of causing more scarring and actually induce a stricture. So I'll do this wall and then I'll do the contralateral wall when he comes back for his subsequent stricture dilatation. So I'm just going to have one more go here. You can see I've got a bit more of a ridge that I can release, and we'll get him on his way and get him back in 2 weeks for repeat dilation. Yes, knife out, please. Thank you. Just want to pivot my knife into that ridge and then get a bit of downward pressure from the endoscope this way around 360 degrees. There we go. That's exactly the bit that I wanted. You can see the muscle fibers underneath, so I probably don't want to go too much deeper here. Of course, operation, but I think that he will definitely benefit from one more session. So I'm going to shave off a bit more here.
So thanks to Rayhan Haydari for presenting that stricturotomy. We've already discussed the indication in my last lecture, so we will go now on to Rami Sweiss's talk on endoscopic therapy for reflux.
Thank you to the organizing committee of the Oesophageal Neoplasia Masterclass for inviting me today to speak about endoscopic therapies for gastroesophageal reflux disease. Until recently, only 3 treatments for gastroesophageal reflux disease have been used. Antacids such as acid-reducing therapies such as Gaviscon, acid-reducing medications such as omeprazole and histamine receptor antagonists, and anti-reflux surgery or LINCs. So anti-reflux surgery is usually undertaken for those who have ongoing symptoms despite PPIs, or those who are not happy to continue to take PPI therapy or acid-reducing therapies. Nissen fundoplication is considered to be the gold standard. It has been around for many years, and there is good response both symptomatically and objectively on pH testing, and there is evidence of longevity. Patient selection, however, is critical. We know from studies such as the LOTUS trial and the Sopran study and others that response to anti-reflux surgery is prolonged. However, we also know that patients who have anti-reflux surgery have a high likelihood of developing side effects, such as dysphagia, epigastric pain, flatulence, bloating, diarrhea. In up to 50% of patients can have these side effects. The problems with the current therapies are that the PPIs have incomplete response in many cases. Recent studies have suggested that there might be complications in the long term with PPIs. There's unwillingness to continue taking them for the long term, and also fear of anti-reflux surgery and their side effects. And of course, we have patient choice. Anti-reflux endoscopic treatments are emerging, and these are considered an alternative with the aim of augmenting the lower esophageal sphincter in order to reduce reflux symptoms and reflux events. There are a whole variety of these procedures that have been described in the literature. Some have come and gone. Some do not have very much evidence behind them. What I will present is the list, as you can see here. Before we talk about these, however, we need to go back to basics. The pillars of good response that predict good outcome following any anti-reflux intervention are as follows. The presence of typical reflux-like symptoms, heartburn or regurgitation, not the presence of isolated atypical symptoms. Complete or partial response to acid suppressive therapy, and of course, an abnormal score on an ambulatory pH monitoring study, which is crucial. It's important to remember that not all patients who describe symptoms of reflux, in fact, have a problem with the lower esophageal sphincter that requires intervention. There are numerous reasons to why patients might describe symptoms, and we have to take these into consideration and look at the patient as a whole. For example, impaired gastric emptying or hypersensitivity, these are not indications for anti-reflux interventions. In order to assess the degree of reflux and the need for intervention, we need to perform tests to objectively measure the amount of reflux that's taking place. The first and foremost is endoscopy, and if there is clear evidence of grade C or D esophagitis, we don't need a pH study to confirm that this patient has reflux. But in the majority of cases, endoscopy is normal, or there is grade A esophagitis, which is on par with normal. So we need to perform pH monitoring studies. The most common are impedance pH monitoring and wireless pH studies. However, there have been some suggestions that perhaps one is better than the other, and this is not true. Both test different things, and we can discuss the utility of each during question time if you wish. In the majority of patients who have ambulatory pH monitoring, these are considered endoscopy negative reflux symptoms. When you perform pH studies, you can divide patients into those who have pathological esophageal acid exposure or not, or positive reflux symptom association or not. By doing so, these patients have objective evidence of gastroesophageal reflux disease. These patients have functional heartburn. In other words, they don't have reflux disease. However, only these patients should be considered for anti-reflux interventions. These patients should not. So what are the anti-reflux interventions? Let's talk about stretta first. There is a delivery of energy supplied to the lower esophageal sphincter through a balloon-based 4-electrode needle array. This is undertaken at the lower esophageal sphincter and just above. It deploys radiofrequency thermal energy. The exact mechanism is unclear. At first, it was theorized that perhaps it causes tissue hypertrophy and reduces transient lower esophageal sphincter relaxations and reduces the amount of reflux that's taking place. However, more recent studies have suggested that perhaps it might influence reflux symptoms by causing fibrosis at the lower esophagus, and perhaps even disrupting the neuronal signaling and reducing the sensitivity of reflux within that area. There have been lots of studies, 3 randomized controlled trials of Stretta with sham, 2 randomized controlled trials with PPI, and lots of comparative trials and cohort studies, retrospective studies, etc. Compared to sham, it seems to improve reflux symptoms based on health-related questionnaires. But the measurement of acid reflux, the acid exposure time, is not different compared to sham. Compared to PPI, again, the Stretta tends to decrease the need for PPI, which is 6 months, but not at 12 months. And the problem with all these trials is that it's difficult to draw conclusions because of the different variables and different scoring systems that are used to measure. So many mixed results, small numbers, short-term follow-ups. So to reach conclusions is not easy. Meta-analyses also depends on whether or not you're including the randomized controlled trials with the cohort studies or just looking at randomized controlled trials on their own. When looking at all the studies, including the cohort studies, Stretta seems to significantly reduce esophageal acid exposure, improve quality of life, and decrease the use of PPIs. When you look at randomized controlled trials on their own, Stretta did not produce any significant changes in acid exposure, quality of life, or ability to stop PPIs. Here is one of the biggest meta-analyses that was published in 2017. If you can see here, from 2 randomized controlled trials and 9 cohort studies, there is a significant improvement in health-related quality of life questionnaires. When looking at acid exposure time, in fact, the randomized controlled trials show that there's no significant difference between sham or Stretta when looking at ambulatory pH monitoring results. Stretta is safe. It does not contribute to major adverse events. The side effects that can occur are temporary and usually modest. So there is no real concern about safety with regards to Stretta. In 2013 and 2015, the American Gastrointestinal and Endoscopic Surgeon Society, American Society of Gastrointestinal Endoscopy recommended the use of Stretta perhaps as a bridge to therapy instead of fundoplication in those who refuse surgery. The NICE guidelines in 2016 suggested that because of the uncertainty over longer-term safety and inclusive efficacy, the suggestion is Stretta should be used with special arrangements for clinical governance and consent and audit and research. But just last year, the American College of Gastroenterologists withdrew their support and said that because of the data on the efficacy of radiofrequency energy as an anti-reflux procedure is inconsistent and highly variable, we cannot recommend its use as an alternative to medical or surgical therapies. So I think that's a bit harsh. I think there might be a role in Stretta for those, especially with a positive reflux symptom association, if we're aiming to neuromodulate. But as a primary intervention to reduce reflux in itself, it's not clear. The next device is called the full thickness plication, or more recently, the GERD-X. This has gone through various iterations over the last several decades. The most recent one shows the most efficacy. The GERD-X produces a full thickness plication. The mucosal device retracts the cardia and produces a serosa to serosa apposition immediately below the gastroesophageal junction, with the idea of reducing the amount of reflux that takes place. The randomized controlled trials of this device versus laparoscopic fundoplication shows that it does improve reflux symptoms, but the fundoplication results in a better response, although the fundoplication does lead to higher risk of post-procedure side effects such as dysphagia and diarrhea. After the plication device used, over 50% do not normalize the distal esophageal acid exposure, and over a third continue to require PPI therapy. The most recent randomized controlled trials, 35 patients who had plication with GERD-X versus sham, and as you can see on the right, the health-related questionnaires results scores at 3 months, 6 months, and 12 months show a clear and significant improvement in those who had the plication versus sham. And there was a 2/3 of patients were off PPIs at 12 months compared to sham. However, pH-metry results improved at 3 months, but not at 12 months. It's a safe device. Very few patients have adverse events. The mild adverse events that can occur, such as chest pain and dysphagia, are transient. This was published in 2018. It looked at the utility of the Apollo overstitch endoscopic suturing system as a means to treat reflux. Patients with clinical features of or diagnostic criteria consistent with reflux were included. Only 10 patients were included in the study. Only 5 of them had ambulatory pH monitoring result testing. All had what they describe as clinical features consistent with GERD, but they don't describe what these were. But all had health-related questionnaires administered before and after the procedure. Here are the details for the 10 patients. You can see that in the majority of them, they all had some form of anti-reflux procedure undertaken. One even had esophagectomy. One had a 5 centimeter height hernia. They're also all fairly large, and there weren't. The median age was 61. The sutures were placed in a simple interrupted fashion from 12 o'clock to 3 o'clock, and then from 3 o'clock to 6 o'clock with reinforcement as needed. The procedure took anything between 30 and 100 minutes. So median follow-up was very short, around 5 months. They all exhibited an improvement in health-related questionnaire scores. 2 were able to reduce their PPI use. 1, in fact, ended up needing more. The median duration of reflux symptom improvement was just 1 month. One patient had nausea and vomiting, but there are no adverse events. So this is just a feasibility study. The authors suggest that its unique benefit of this approach is that it allows for us to customize an endoscopic approach to these patients' anatomy. So it can be used in patients who have previous interventions, such as fundoplication, esophagectomy, sleeve gastrectomy, and even large hiatus hernias. The anti-reflux mucosal intervention, also coined ARMI, from this this review that was published last year from the a group in Taiwan, is an umbrella term for 3 procedures that have similar concepts. The anti-reflux mucosectomy, or ARMS, whereby EMR is performed in order to cause injury at the cardia. The anti-reflux mucosal ablation, whereby ablation is performed. Again, both of these are in a butterfly fashion. And the anti-reflux band ligation, which uses band ligation in order to cause trauma and injury in the cardia. This then leads to healing, and the theory is that the healing causes the lower esophageal sphincter and the cardia to contract and reduce the amount of reflux. All of them use pre-existing techniques and devices, so it should be cost-saving. There are lots of studies that have been published. Most are cohort studies. There are 3 comparative studies, 2 with PPIs and 1 with anti-reflux surgery. No randomized controlled trials. Most are retrospective. The optimal technique remains unclear. The short-term follow-ups tend to show that symptoms improve. About 2/3 have discontinued PPIs at 6 months, and just over half still did not require PPIs at 12 months. And there is evidence of reduced degree of esophagitis. Those who have ambulatory pH monitoring undertaken, there is a reduction or normalization at 3 months, 6 months, or 12 months, according to whichever study you're looking at when measuring acid exposure time. Adverse events can occur. Primarily, the ones that have been published are in the ARMS group, which can be bleeding, perforation, or pain and dysphagia. In the majority of patients, the perforation could be managed endoscopically, except for 1 patient that was published. And dysphagia in the majority of patients was treated endoscopically as well with dilatation. About 10% of patients required some form of salvage anti-reflux intervention. Transoral incisionless fundoplication. This has been perhaps the most studied technique. It uses the Esofix device to endoscopically suture H fasteners, which are non-absorbable sort of plastic devices you can see here. There have been two iterations. The TIF1 used only 12 fasteners, while the TIF2 in fact reconstructs the gastroesophageal valve by creating a 270-degree fundoplication and uses approximately 20 of these H fasteners. So this is a more advanced technique, and we need to be careful with the results because many of them include results from the TIF1, which are less efficacious. There have been lots of studies looking at this, 5 systemic reviews and meta-analyses, randomized controlled trials looking at TIF versus sham versus PPIs versus laparoscopic fundoplication, and there has been long-term follow-ups of up to 10 years. Data from the randomized controlled trials versus sham shows that the TIF device improves reflux-like symptoms such as heartburn, regurgitation. Health-related quality of life scores improve compared to sham. The acid exposure time either reduces or normalizes. When the TIF versus PPI also shows that it reduces the need for PPIs up to 5 years. It reduces acid exposure time on par with PPIs. TIF is superior to PPIs in reducing volume reflux such as regurgitation. Those who are followed up at 10 years shows that many remain off anti-secretory medications, and the majority who do resume PPI usually have it at a lower dose. Here is one of the largest meta-analyses in 2018, 32 TIF studies, and it shows that there is nearly 100% immediate post-procedural success rate. Symptom scores improve significantly, and there's an improvement in acid exposure time. The meta-analysis from 2019 again shows similar results, and again shows that acid exposure time either normalizes or improves significantly. In this study from Richter et al. From 2018, it shows that the TIF device led to the best health-related quality of life score compared to PPI or Nissen and sham, but the Nissen fundoplication led to the best outcome based on ambulatory pH monitoring. Now, there was a suggestion that perhaps TIF is useful, particularly in those with atypical symptoms. Based on this study is a retrospective analysis of 10 studies looking at 564 patients, all of whom had TIF2 or TIF with crural repair. And it did suggest that at 6 months and 12 months, there was an improvement in the RSI score, the reflux symptom index, which is a measure, a validated symptom questionnaire. And so on that basis, it suggested that TIF is useful in patients who have atypical symptoms. However, when you look at each of these studies, all of these studies are not exclusively atypical symptoms. They all include typical symptoms of heartburn and regurgitation. These are not isolated atypical symptoms. We have to be careful not to interpret this study as saying that those with isolated atypical symptoms of LPR should be considered for TIF. And in fact, when you go back to basics and you look at the studies looking at LPR and anti-reflux surgery, for example, there was a recent review article looking at all the studies that looked at anti-reflux surgery following for patients who had LPR symptoms. Of the 844 studies, these were all screened out and dwindled down to 9. And of these 9, you can see that the numbers are small, the follow-up period is short. They're primarily prospective case series rather than randomized trials. The only study of value that I could see from this table is this one from Serhat Bor's group from Turkey. And this was a prospective single-blind case control study looking at GERD versus LPR group. And it did show that patients in the LPR group did improve, but all of them also had symptoms of heartburn and regurgitation, and all of them had clear evidence of pathological esophageal acid exposure. The other study that we just mentioned with TIF did not include measurements of acid exposure. It was only based on symptoms. So we need to be very careful when we interpret these results. TIF is safe. Only 2% of patients reported serious adverse events, and 50% of those serious adverse events were in the TIF1 group rather than the more advanced TIF2 group. No perforations were seen or reported in the 5 randomized controlled trials using TIF2. So on that basis, the American College of Gastroenterologists just last year supported TIF primarily for those with endoscopy negative reflux who do not have severe esophagitis, grade C or D, and who do not have a Heights hernia greater than 2 centimeters. So based on all these procedures, I propose this algorithm. This is not published. This is just my interpretation of the data. If you have esophagitis, grade C or D, fundoplication or the LINX device is recommended. These have clear evidence that they reduce objectively acid reflux and reduce esophagitis. If you have endoscopy negative reflux disease, remember this algorithm about how patients can be divided based on ambulatory pH monitoring. And if you have negative acid exposure and negative symptom reflux association, this is not reflux and we should consider neuromodulation or other causes of symptoms. If you have a positive acid exposure time plus minus a positive symptom reflux association, and you have a Heights hernia that's greater than 2, we should be considering surgery. If Heights hernia is 2 or less, then we should be considering procedures such as LINX, TIF, maybe even ARMI or GERD-X. Those who have a negative acid exposure time and a positive symptom reflux association with a Heights hernia that's small, perhaps this is where Stretta fits. And those who have a Heights hernia that's greater than 2, and you're convinced that in fact this patient should have pathological esophageal acid exposure, perhaps it was just missed on the test, we should consider repeating the test or consider another form of test. So if you did an impedance pH study, perhaps try using a wireless pH monitoring device or vice versa. Thank you. Questions?
Thank you, Remy. That was a really great lecture. And the algorithm was really very useful. Please send me a copy because I'll start using it. So I always struggle with the patients who kind of fall between the obvious patients who want surgery for good reason, those who've got objective evidence of acid reflux, typical symptoms, and respond to PPIs. But the vast majority lie outside that group. So what's your own practice when it comes to the indications of patients who you would then end up referring for surgery or TIF? And you can maybe elaborate on who you'd then send to TIF that has the best data, obviously, and Nissen fundoplication or LINX.
That's the question that most surgeons and physicians ask me, in fact. And the problem is availability, not just appropriateness. So the availability of these endoscopic therapies is not available in the NHS primarily. Mm-hmm. Only a handful of centers do some form, like Stretta, for example. But elsewhere and in the private sector, obviously they have there are the options of perhaps performing TIF and others. Now, when it comes to decision making with regards to which procedure to undertake, I think what's more important is to determine who should not have endoscopic therapy versus who might be considered for it. And the biggest indication is the presence or absence of a Heights hernia. A big Heights hernia, we're talking 3 centimeters, 4 centimeters. These patients should not be having endoscopic therapy primarily, because we're forgetting that the diaphragm and the anatomy of the separation between the diaphragm and the lower esophageal sphincter needs to be taken into account. We need to correct the hernia as part of the procedure. Many of the patients who have LINX device, which is placing the magnetic ring at the lower esophageal sphincter, these also have concomitant tying of the right cross, and so that will also help with the lower esophageal sphincter anatomy and structure. So these techniques are all lower esophageal sphincter alone, or even just mucosal when you're talking about Stretta, for example. So if you have a big Heights hernia, then we should not be considering anti-reflux interventions, whatever they may be. If you have severe esophagitis, grade C or D esophagitis, I think you need to go to whatever has the most evidence. The most evidence is anti-reflux procedures such as Nissen, Toupet, whatever, the ones that actually change the anatomy. These are gold standard as it stands. Everyone else is in between. We have the most important thing to do is to determine, is the reflux indeed coming from a incompetent lower esophageal sphincter, or is there something else happening like gastroparesis? And if it is, not uncommonly we see patients coming having had the procedure done in the lower esophageal sphincter when in fact the problem is well beyond, and then you have a double problem. And then in that context, if you have clear evidence of pathological esophageal acid exposure, then we can decide between the two, and then the decisions are based on availability and patient choice, and that sometimes is the limiting factor.
Exactly, and the patients themselves may simply not want to take PPIs even though they respond well. I'm going to move on now to the next session. Thank you, Rami. And I want to introduce Yasser Qureshi, who will kick off the next talk within the session. Hi, Yasser, good to see you again. And the next session is Advanced Therapy for Esophageal Cancer. And I'd like to welcome back Rehan Haidri and Vinny Segal. So over to you, Yasser, consultant colleague at UCH and upper GI surgeon. Thank you very much.
My name's Yasser Qureshi. I work here at UCLH as a upper GI surgeon, and I'll be giving a brief talk on updates on the surgical aspects of esophageal cancer management today. I know that most of you are gastroenterologists, so I'll try not to bore you with too much technical detail, but I'll just give a background of the main operation we perform for this disease and then go over a few aspects of care which have impacted our surgical management of these patients over the last couple of years, and what we think will have an increasing impact in the coming years ahead. And then we'll try putting all that together in a brief summary. So the esophagectomy, namely the Ivor-Lewis esophagectomy, which involves a right thoracotomy and a laparotomy, remains the mainstay of curative treatment for esophageal cancers which are T1B or greater and those with nodal disease. And this is usually associated with neoadjuvant chemotherapy, followed by adjuvant chemotherapy after surgery, usually with the FLOT regimen in the UK. Now, not too long ago in the 1970s, the post-operative mortality rates were high as 35% following this operation, but thankfully that's come down to between 1% and 2% nationally in the UK over time. But nonetheless, it still remains a significant operation with about a 10% risk of a major complication, by which I mean an anastomotic leak in the chest, which can be potentially disastrous, a chylothorax, which often requires a repeat thoracotomy, or significant cardiorespiratory insults following surgery. And the other key thing to remember is that the thoracotomy aspect of the operation, which lasts approximately 3 hours, the patient does require single lung ventilation. So for this period, they are breathing entirely on the left lung, and that has implications for some patients, as we'll come on to. The operation involves a subtotal esophagectomy, so you remove approximately 70% of the esophagus and about 50% of the lesser curved side of the stomach. You then bring the stomach up into the chest and perform the anastomosis. So you are removing a significant amount of both esophagus and stomach, which has implications for the patient's dietary habits in the future and their overall quality of life. So now moving on to the trends that we've noticed, as I said, mostly in our practice, but it might be replicable in other units as well. Firstly, it has been the change in patient management. Now that 35% mortality rate in part was because of patient selection, but we've also had improvements in anaesthetic care, intensive care unit stay, and indeed selecting patients which are would do well after an operation. But nonetheless, despite all those advances, the median age of presentation for this type of cancer in the UK still is in the early 70s. 60% of patients have a history of either smoking with associated significant respiratory disease, or obesity, or significant cardiovascular disease. And in the last national audit, about 2 years ago, up to 20% of patients are declined surgery owing to fitness. Now, these are patients with otherwise operal disease, so that remains quite a major concern. I've also performed a study here at our unit analyzing 700 consecutive oesophagectomies, and what we found, that you can see in this chart, is those patients with a significant complication, so clavien dindo 3 and 4, which are the bottom curves, have a significantly reduced overall survival. And the implication of this, that these patients who are undergoing major surgery, toxic chemotherapy in an attempt to cure the cancer, may not be having the benefit in their overall longevity because of suffering a complication. And that is quite important to consider when counseling patients and determining the optimal treatment for them. But what's happened in the last couple of years, and certainly we've been more proactive in this over the last year in our own unit, is setting up what we call a prehabilitation program. Now, before surgery, if the patients do have chemotherapy, you have about 4 months to really try to affect the overall health and the physiology of the patient by a combination of physiotherapy and graded exercise programs, cardiorespiratory optimization in specialist clinics, being managed by a specialist nutritionist. And we also here in this unit use cardiopulmonary exercise testing, which is a useful marker of physiological improvement. And what we do know, that if we can improve some of the metabolic markers such as anaerobic threshold and maximum oxygen consumption by a quarter or so, we can lower the risk of major complications by 20%. What we're also able to do is shift some patients who may be borderline fit for surgery into fit enough for surgery. And we hope that over time that we can improve not only the overall health of the patient, but thereby impact the overall survival for these patients as well. So that's something I think most units will certainly adopt over the coming years, is really trying to work hard to improve the overall health of the fitness, not just in terms of getting through the operation, but also in improving their overall health in the distant future as well. Now, I'm sure most of you have heard about robotic surgery, and you can see on these two graphs the incisions, which are all either 1 centimeter or 0.5 centimeter in size, both in the abdomen and for the thorax. And that's significantly different from having a large laparotomy and thoracotomy. And robotic surgery, certainly over the last few years, and now increasingly in upper GI units, is coming to the fore. This is a series of papers published over the last few years showing equivocal outcomes in terms of oncological benefit, but also equivocal or slightly better outcomes in short-term assessments for these patients. And it just goes to show the purpose of this slide is not the details, but just goes to show that a lot of units are now adopting the robotic method. Now, the benefits of robotic surgery are purportedly a reduced level of post-operative complications, despite equivocal oncological outcomes. And by oncological outcomes in this context, I mean the resection margin status and the lymph node yield. The purpose of the smaller incisions, by and large, is to reduce hospital and intensive care stay and get the patient to return more quickly to their baseline function, including work. And then some studies with longer term data have suggested a dramatic improvement in quality of life for these patients. And although robotic surgery is becoming increasingly popular among surgeons, I must add a word of caution. The units who've published their data, who have had really outstanding results, have been doing robotic surgery for 10, 15 years, really since the inception of this type of surgery. And so they've got excellent experience, which they've improved year after year with, now thousands of cases under their belt. And those results are not replicable everywhere. There is a very, very steep learning curve for this operation. Most of us who've trained in open and laparoscopic surgery are not trained in robotic surgery, and it's a completely different operation. So you are having to learn from scratch in many ways. So it will take time for the rest of us to catch up. And particularly in the context of the way the NHS is now, the technology still remains quite expensive. So although some units will be getting onto the bandwagon of robotic surgery, I don't think it will be so widespread until the next 5-6 years, when the technology perhaps becomes a bit cheaper. But certainly, I think in the next 5-6 years, you'll notice more and more surgeons adopting the robotic approach to an oesophagectomy, which will then become the sort of standard of care. And then finally, and perhaps the most important thing which we've noticed in our practice has been the personalization of treatment that patients get, usually through the MDT. Now, just an example of this is the concept of salvage surgery, which historically would only ever perform for patients with recurrent squamous cell carcinoma. This is after they had received definitive chemoradiotherapy, but had some evidence of disease coming back, which was resectable. But there was always a variable survival benefit in this, and you're subjecting the patient again to a big operation, not knowing how soon the disease would recur. But over the last year or so, we've noticed increasing number of salvage esophagectomies that we are performing for adenocarcinomas, which previously had been incredibly rare. And we put that down to the use of the new class of immunotherapy, namely the checkmate inhibitors. And here's some of the bigger trials which have assessed immunotherapy agents for patients with esophageal adenocarcinoma, and there's quite modest improvements in survival. But what we are noticing is that a small group of these patients on these treatments are being shifted from either inoperable locally advanced cancers or on a few occasions with metastatic disease at presentation to now an operable cancer. And so we've certainly noticed an increase in the number of esophagectomy performing for this group of patients. And as our knowledge widens about the effects of these immunotherapeutic agents, I think that we'll probably be performing more salvage operations for patients with adenocarcinoma over the coming years. That's certainly been our experience in our unit over the last year or so. And following on from that, one of the things which has really quite exploded over the last decade has been endoscopic treatment for esophageal cancer. We learned inadvertently during COVID that the true role of what endoscopic treatment may have in the future. And the reason for that is our patients were diverted from receiving an esophagectomy for adenocarcinomas to definitive chemoradiotherapy owing to the risk of perioperative risks with concurrent COVID. But once the pandemic subsided, we were sort of stuck with a group of patients who had radiological remission. And so we weren't quite sure whether to just surveil them or then to proceed with chemotherapy when it was determined safe to do so. But we sort of managed this on a case-by-case basis. I'm sure my colleagues here may enlighten us further on this, but there was a group of patients who had responded so well, yet with some small volume of residual disease, that they were now candidates for endoscopic treatment, so an EMR. And that experience of this handful of cases really got us thinking that perhaps in the coming years, what may play a big role, particularly for patients who are unfit for surgery, is whether an EMR can be coupled with either immunotherapy or chemoradiotherapy. So those with slightly adverse features or slightly increased tumor depth than we anticipate, or those with a higher risk of occult nodal disease, whether you can combine an endoscopic resection along with systemic treatment such as radiotherapy or immunotherapy. And I certainly think that this avenue will be explored increasingly over the coming years, in large part owing to the development of immunotherapy agents, but also with the expansion of interventional and endoscopy. And the reason why I say this is because the risks of an esophagectomy with single lung ventilation in terms of perioperative mortality, major morbidity, quality of life implications is dramatically different to those patients who may be cured simply with EMR. And for that reason, certainly I think that over the coming years, we'll be exploring this concept a bit more, and perhaps they may change our treatment protocols for a significant number of patients. In summary, and this is one of the important things that I've thought a lot about over the years, is that within our MDTs, we presently consider the T and the end stage when determining optimal patient treatment. But we do know that the biology of these cancers is dramatically above and beyond what both the T and the end stage suggest. And in large part due to the developments in immunotherapy, we're learning more about more detailed cancer pathways. And I think that will lend itself well to a more personalized approach to the care. And what we can do in the meantime as surgeons, as gastroenterologists, is to continue to collaborate as we are, whereby combining endoscopic treatment, perhaps when adverse features are found with surgery or increasingly with novel treatments led by oncologists, I think we can really drive the improvement in survival that we all seek, yet avoid the implications of having a a big operation like an esophagectomy. So I think those are some of the main improvements and changes we'll see in our practice over the coming years. Thank you very much for listening, and I look
Thank you very much, Yasser. That was a really excellent overview of a surgical space that it's always important for us as gastroenterologists to be aware about and know ever more so about. I'm just going to pick your brains on a couple of ideas and a couple of topics that were discussed earlier on in the day. So we historically have been quite anxious about T1B disease as gastroenterologists, and we know from retrospective surgical series, particularly esophagectomy specimens, that there is a not insignificant rate of lymph node metastases. But these patients often, as you alluded to in your talk, are relatively elderly with polycomorbidities and not ideal surgical candidates. And there is a lot of research going on to whether we can actually monitor these patients very aggressively using a triple phase approach of endoscopy, EUS, and very vigilant PET-CT scanning instead of sending to surgery. And we'll be interested to see what comes out of that data. From your surgical experience, however, does that fill you with any hesitation, or do you think that we should be more aggressive with these patients?
Yeah, thanks, Vinny. It's a difficult one because, as I alluded to, 1 in 5 patients are not candidates for an esophagectomy owing to fitness, and there's still quite a significant number of patients who might otherwise have been cured. And it's difficult to turn them down, but the risks of surgery are too high. And I do think that this group of patients would be the type of patients to begin with who would benefit from EMR, perhaps coupled with more localized therapy for occult nodal disease, such as localized radiotherapy, because an EMR is it's in terms of physiological insult is far less than an esophagectomy. So yeah, as a surgeon, you don't want to shortchange patients in terms of trying to cure them from cancer, but at the same time you do have one eye on what the risks of it are, and the reason we're perhaps a little bit more cautious when determining whether a patient is fit for an esophagectomy is because we see them on the other side, a few weeks or a few months down the line where they're really struggling. So I think quite right. I think the sort of borderline fitness, unfit patient group are an excellent group where EMR with little physiological insult, perhaps coupled with other treatments, would be a good group to study further. And we kind of saw a bit of that during the COVID pandemic with a diversion of our normal treatment pathways.
Yeah.
Thanks, Yasser. Really helpful reflections, and actually just picking up on that. COVID made us all think outside of the box, but also amend our practice, less so on evidence, but more so on the resources available. But let's just pick up on that group that you said who had definitive chemoradiotherapy because of the lack of availability of surgical intervention, and then when we restaged them, the disease was less bulky and perhaps localized, and there is emerging data now to show that after chemoradiotherapy, that endoscopic submucosal dissection, as a sort of salvage intervention, can be helpful. What are your thoughts on that? Do you think that's something that we can look at in more comorbid patients, or perhaps patients who choose not to have surgery? Is to perhaps look at that approach. Of course, it is a case-by-case basis, and these resections are very, very difficult to do afterwards because the tissue planes are often pretty mangled because of the fibrosis. But what are your thoughts on that?
Yeah, no, I agree, Dr. Hadri. I think the big issue is that the risk of nodal disease, which usually is quite occult with these very early cancers, but that's what we're treating with an esophagectomy, really. And yeah, a lot of these patients have with very early cancer with no obvious nodal disease, but with adverse features. We go on to perform an esophagectomy, and we haven't really gained anything. The tumor is all resected by EMR or ESD. So I do think, there is a role for exploring that data a bit further. How many patients post EMR are actually benefiting from an esophagectomy? I think that's something which is quite variable, but certainly something that we should look at in a bit more detail. But you're right. I think the real group of patients who we could start by treating in such a manner are those patients who are not fit for surgery, because we can cure them, but owing to the risks of the operation, we're not doing so. So I do think they are a group where we can treat them a bit more aggressively endoscopically, except that they may have some adverse features or higher risk of recurrence. But like I said, in a lot of these patients with perhaps say even T1B cancers, they may not develop nodal disease. It's difficult to predict. The way that our gold standard is at the moment with an esophagectomy for anything of T1B or above, if you can't do an esophagectomy, then I do think that you have to look at alternative treatments for these. And I think we had some good experience of endoscopic treatment coupled with systemic therapy for some patients who did quite well in the just after the pandemic.
Listen, sir, thank you so much for taking time out of your busy schedule. I know you're still operating, and I really appreciate the effort you've made with the talk and also joining us. And we'll let you get back to it, and I'll see you at work tomorrow. But what we're going to do is we're going to move on slightly and talking about a little bit more of a nuanced area of esophageal cancer here, where we're looking at fistulating disease, particularly in the proximal esophagus with the airway. And it's my pleasure to invite my consultant colleague and one of the interventional bronchoscopists, Dr. Ricky Thakra from University College Hospital, who's dialed in. Hi, Ricky. Hi, Ricky, how are you? Okay, so we've got a problem with the audio slightly with Ricky at the moment. What we'll do in that case, let's go to the case itself, and while we re-establish the audio link with Ricky, and then we'll get Ricky on the line afterwards. So if we can get the case slide up, thank you. So the case is a 70-year-old gentleman with a new diagnosis of esophageal SCC. On cross-sectional imaging, he was found to have a 10-centimeter tumour extending from the mid to lower esophagus, but unfortunately fistulating into the left main bronchus. So this is going to be a case demonstration both endoscopically but also from a respiratory aspect in bronchoscopy. The tools used are a Pentax I-10 gastroscope. We're using a Boston Scientific Jaguar and a self-expanding covered metal stent. The bronchoscope being used is Olympus series. So if we can go through to the case, please.
This is a scan of a patient with a known diagnosis of esophageal cancer who presented to his local hospital with breathlessness. You can see a large left-sided pleural effusion and in the mediastinum a dilated esophagus due to a large esophageal cancer. As the trachea divides, you can see there is obstruction and erosion of the left main bronchus, causing complete collapse of the left lung. The pleural effusion is likely to be reactive to the airway collapse rather than a malignant effusion. He was transferred to our care for a joint procedure with GI colleagues for a bronchoscopy and esophagoscopy. So this is the patient's bronchoscopy, and to provide orientation, at 12 o'clock is the posterior wall of the trachea, and at 6 o'clock the anterior wall. So going into the left main bronchus, you can see the esophageal cancer eroding through the posterior wall, causing near complete obstruction. We have taken some measurements for a suitable self-expanding metal stent, which we place using a direct vision method. Here you can see a wire being passed through the working channel of the bronchoscope, which we aim to pass into the distal airways. We then pass a self-expanding metal stent catheter over the wire, while a second operator follows this stent using the bronchoscope. As with esophageal cancers, we want to make sure there's a sufficient clearance in the proximal end of the bronchus and also the distal end of the bronchus as well. So the bronchoscopist now is following the stent to the distal left main bronchus, aiming to open the stent just as the left upper lobe and left lower lobe divide. And that's the left upper lobe and left lower lobe divisions just there. The bronchoscopist is performing bronchial aspiration. You can see there is considerable pus trapped in the airways, and this is as a result of an obstructive pneumonia from the esophageal cancer causing complete airway collapse. The distal end of the stent is placed in the distal left main bronchus. The sheath is withdrawn, and this allows the stent to open up. The bronchoscopist then follows and retreats as the stent opens up. We perform airway stent insertion with a direct vision method like this to ensure that we have placed the stent as accurately as possible across the stricture. In this case, you can see the proximal end of the stent is a little bit distal, and so we use some forceps to grab a purse string that causes the stent to constantina, and we can make small adjustments by pulling it proximally until we are satisfied that it's in an appropriate position. This is a nitinol self-expanding metal stent with a PTFE covering and has one of the strongest radial forces on the market. However, you can see it's causing, the tumour itself is causing the stent to buckle, and in this case we are using a 12mm balloon that we are passing into the lumen of the stent so we can give it a little helping hand to open up. As the stent warms to the body temperature, it will expand similar to esophageal stents over the next 48 to 72 hours. However, in this case, we do want to make sure that we can see the distal end of the stent has opened in an appropriate position. The balloon dilatation allows us to do this and pass the bronchoscope through the stent. And confirm that the distal end of the stent has opened up in the perfect position where the left upper lobe and left lower lobe divide. We perform a final balloon dilatation, and in this case, once the airway is secure and the patient's left lung has expanded, we hand over to our GI colleagues to assess the esophagus.
Thank you, Ricky. So I am Vinay Sehgal, GI consultant at UCLH. I'll be performing the gastroscopy in this patient. You can see the nasogastric feeding tube in the distance, and you can, if necessary, use this to help you guide you into the esophagus, although this is not always necessary. Upon intubation into the esophagus, the first thing you can identify, in addition to the feeding tube, is a large column of liquid above what looks like a polypoid tumour. So I think at this stage, my first priority will be to aspirate and suction out as much of this liquid to avoid the risk of the patient aspirating. You can also ask your nursing staff to raise the head of the patient's bed here to get gravity on your side. Once you have aspirated the fluid, it becomes very clear that it will be impossible to pass this tumour with a gastroscope, and therefore I will do a on-table barium study to delineate the nature and length of the stricture. Therefore, inject contrast through the working channel of the gastroscope, and as you can see initially, the vast majority of this has refluxed back behind my scope. If we continue to cautiously inject further contrast, you can begin to see some seeping through the stricture, and this will give you an idea as to how long your stricture is, and therefore deciding what length stent you need to use. So this looks like an approximately 4 to 5 centimeter stricture. So I will use a 11 centimeter fully covered Aegis stent here, and I will want to position the top of my stent such that it is 5 to 6 centimeters above the tumour, such that the middle of my stent is within the stricture. I can do this most easily by using an injection needle to inject a bleb of contrast under fluoroscopic guidance to help me when I deploy my stent. So this is a pretty straightforward technique of injecting into the submucosa and asking your radiographer to screen live at the same time. And this will serve as an important roadmap when you begin to deploy your stent. I'll now remove the nasogastric feeding tube and now pass a wire across the stricture. I tend to reach for a jag wire due to the floppy nature of its tip. And as you can see under fluoroscopic guidance, it is passing relatively easy through the stricture and into the stomach well below the diaphragm. It is important at this point to bring the screening back so that you can visualize the top of your scope. And I often ask at this point to fix this image on the right hand side so that it serves as an important reference point before I deploy any stents. I insert the stent over the jag wire, first visualizing the distal markers and then the proximal markers. I can then line these up with my earlier marker from the contrast injection. When I am ready, I can begin deploying the stent. It is important to hold the stent with your left hand and release it by pushing forward with your right. And during this process, provide continuous traction and pull back on your stent to avoid it slipping into the stricture. So it's that continuous counter traction as you deploy the stent, and you can see the distal aspect of the stent begin to open up. And you continue to use your markers and the contrast bleb to make sure that they are aligned. And with further deployment of the stent, which is almost released at this stage, you begin to see the stricture and the proximal flange of the stent open up. I can then re-intubate the esophagus and can be confident that the proximal aspect of the stent is well above the tumour. You can at this stage perform another fluorogram using contrast to check flow across the stent. So an on-table contrast study here confirms passage of contrast through the stent into the stomach. It is also important at this stage to know that it is not important to try and traverse the stent with your scope, as that will risk pushing the scope into the stomach. Thank you for watching.
Nice.
Okay, thanks, Ricky. Can you hear us now?
I can. Hopefully you can hear me too.
Brilliant.
Hi, Ricky.
Yeah, thanks for joining us,
Hi,
Ricky, this
Ryan.
afternoon. Listen, I want to pick your brains on something. As gastroenterologists, we sometimes are not sure when to call for help from a respiratory colleague in these cases. What would you tell a gastroenterologist that they need to look for when they're thinking about contacting an interventional bronchoscopist such as yourself before we put a stent in? What are the things that are going through your mind? What do you want to know?
So Vinay, Rehan, as you know, we do a lot of these patients as joint cases, don't we? We look at them together. We do a bronchoscopy and a OGD on the table before deciding what to do. I think the learning points would be for any individual who has an obstruction to their airway. So if you have say an esophageal cancer, like in this case, pressing on the airway, or a very large mass that you envisage, if you're going to place a stent, you're going to push that mass and cause airway obstruction, or there's a fistula. All of these would be very good reasons to involve an interventional bronchoscopist in the case.
Yeah, and I think the first thing, Ricky, I think you'll know that I always do, is I get you to look at the scan. So whenever there's a query, you want to sit down with your respiratory colleagues and actually go through that scan in detail and plan it before you invite them for the procedure. But Rehan, I'd like to you've kind of gone through this with me. What's your kind of algorithm on the day? Because we're working together in tandem. What are the sort of things that are going through your head endoscopically? And then we'll ask you, Ricky, about when you put a stent in. Do you put it in the airway? Do you put it just in the esophagus? Do you put it in both? How and when do you decide that?
I mean, look, I think we're very lucky to have, the likes of Ricky, and you, David, Matt, myself. We do these, I'd say 2 a month with Ricky and the team. I think there's a lot of considerations here, because what you've just demonstrated very elegantly is a pretty invasive procedure, and the physiological hit to these patients is not insignificant. So, although it's a handsome procedure and the outcome endoscopically looks very good, you just need to take into consideration actually what impact this may or may not have on the patient's quality of life, but ultimately their survival. And I think those discussions happen before you do the endoscopy, i.e. looking at scans, but also, as you and Ricky know, the anesthesiologist who's sedating this patient is probably the most worried person in the room as we deploy those stents. And we've all been there when we've opened an esophageal stent and the patient stops breathing. I think although our practice has been to dual stent, and a lot of people have looked at this, there is divergent guidance on whether that is the best thing to do, especially in the context of fistulation and ongoing subsequent complications. I think these are very difficult cases that have to be managed on a case-by-case basis. I think that the indications for a single versus dual stenting are often there's a grey area in between, and it often comes down to discussion between yourself and your respiratory clinicians, because you have to very carefully choose the lumen of your stents. And this is where it's really important. We were talking last night on the ESGE webinar on stricture management, is knowing your stents, Vinny, and Ricky. Know what the radial force of certain stents are. Some stents are smaller than others, just so you're not getting this sort of counter traction. So I think, look, a very elegant procedure, but in the context of these are palliative patients. And we have to, make a very weighted decision sometimes, is that we do not adversely affect their prognosis by what is, a fairly intensive intervention.
Yeah, that's really useful and interesting to know. And Ricky, in terms of, if we look at the airway stent for an aspect, are there any considerations where you wouldn't put an airway stent? Is it Do they have complications? Are there things that you worry about putting airway stents into patients, particularly when they've got an esophageal stent in situ?
Yeah, good question. I'm probably going to pick up on what Rayhan said, really, about discussing with the patient first, and also coming to a joint clinical decision on what's absolutely best for the patient. So last week we had two patients. I think one was with you, Vinay, that we did jointly, and one with David Graham. So just to talk about those two patients, in one patient who had an esophageal cancer, he was treatment naive but had a fistula into his left main bronchus. Now we were able to we looked down with a bronchoscopy first, and then an esophagoscopy that David did, and we ended up putting a stent just into the left main, into the bronchus. We were able to cover the fistula completely, and the patient was able to still continue to eat. And had the patient had both an esophageal stent, for example, and a bronchial stent, as Rayhan said, when they two stents come together, actually the cause, you could make fistulas worse and make the situation worse for patients. So I think it comes down to a sort of a discussion with the patient, and taking on the other point from Rayhan, which is about very often these patients are palliative, and some may have come to the end of their treatment, and so one of the patients we did not that long ago, his wishes were to eat and have something orally. So we obviously took the risk of doing a dual stent to protect the airway and allow him to eat, and that was really important to him from a quality of life perspective. Regarding stents in the airway, I mean, as with esophageal stents, I'm sure they all cause mischief. So in the airway, they cause lots of secretions. They frequently get occluded, and they can migrate. So really, we want to avoid stenting where possible, and that's sort of always the mantra. But we have to sort of look at each individual case.
Yeah, so I think the message here is case by case basis, difficult patients, and you've got to really understand what the patient's wishes are here, and prognosis and life expectancy. And these are all the thought processes that are going through all of our heads when we're doing this procedure. This is not a straightforward intervention, like Rayhan said, and it's often complex, and sometimes there is no perfect answer. You go for the best answer on the table at the time, and you sometimes live to fight another day. So Ricky, thank you so much for taking the time out this afternoon. Really valuable expertise, and an area that's of kind of growing interest and a lot of traction going in there moving forward. So I'm just going to kind of talk to you about a couple of cases now, just between Rayhan and I, such as some special circumstances. So the case that I will next present actually is a patient who had a benign esophageal stricture, a refractory benign stricture, which I know is slightly off the cards in today's talks, but this is a patient that had failed numerous dilatations, and also had failed steroid injections. So she agreed to have a temporary esophageal stent, and in these cases I would elect to suture these stents in place to reduce the risk of migration. So can we just play that video here? So this is the patient I did I think earlier last week only. So what I think in my experience of this, when you're suturing in the esophagus with stents, I work very closely. I don't tend to use the helix in this case. So this is the Apollo overstitch device here, the SX device, a single channel. And my practice, I don't know what yours is, Rayhan, I tend to put two sutures in, one on each wall, so that there's equal tension. You've done more of these than me. What is your when do you choose to suture a stent in, for instance sake? What's going through your head?
So I think that the indication for the stent is obviously important. I think if we just go back to malignant stenoses, where a stent may outlast the patient if it's a palliative procedure, then you want to do everything you can to try and mitigate the risk of migration, and that's especially important if you're putting a stent across the junction. So you're very you're skilled endoscopists like you who can suture. Not everyone can do this. It's a very specialized procedure. You have over the scope clips. So I think that's when you'd want to suture. And then again, in a situation like this, obviously the indications for stenting in benign disease is up for debate. But again, this is something that's going to be coming out. So a fully covered stent. My preference is just, as you know, to suture, just because, one, they're easy to remove. You don't need any added equipment like the DC cutter for the Avesco stent fix. I have a slightly different approach now. I used to do what you do, which is just to place 2 sutures. I'll put my first suture now, if I can, in the middle of the stent. So I'll go all the way down and actually anchor the stent right in the middle. And I'll just take a single, I'll take the tissue driver, either the 9 or the 3 o'clock position, and place my first stent. Probably at the narrowest part of the stent. And then I'll come back and I'll do what you're doing here, which is put a suture. And I'll try not to put them on contralateral walls, because what will happen is the stent will come together. Right. So I normally place one in the 12 o'clock and then the 5 o'clock position. Look, this is, what you're demonstrating here is very elegant. It's, there's no need to use the helix. You also need to make sure here that you leave plenty of tension on your suture between your stitch that you take within the suture, your intra-stent suture, so to speak, and then your more oral stent, because the esophagus is constantly moving. And if you make that too tight, they will rip. Yeah. So look, another a really nice demonstration here of using the device, and the stent will not migrate.
Yeah, and we leave them in usually for 8 to 12 weeks, and we use the endoscopic scissors when we bring them back to very quickly cut the sutures. That's a lot more simpler to do than sometimes removing the stent fix device, which is a little bit more clunky to remove with a specialized cutting kit. So just there's something to think about moving forward. And one final thing that I think is an area of growing interest, and somewhere I'm interested in, is the closure of chronic fistulas and leaks in the esophagus. And I know you've got a lot of experience in this, Rayhan, and you get a lot of referrals about these very, very difficult and resistant patients. And one thing I wanted to discuss, and we'll be learning more about this, is actually the VAC stent. So this is a tool. If we can play the VT while we talk about this. So this is an endoscopically deployed stent, so containing nitinol and a 5 centimeter polyurethane sponge, which is deployed intraluminally. And I should say the video that we're going to be playing here is courtesy of Dr. Roos Pauw and her team at the Amsterdam Medical Center, who have kindly shared this video with us. So this is it's an interesting device where you actually deploy this endoscopically, you connect it to negative pressure, and you exchange this stent every 7 days. And the hypothesis being behind this is that you will dry up the area that's sort of producing a lot of pus. You'll increase permeability and vascularization and get this tissue to heal. So in this case here, we can see a patient that's had a quite nasty Bauhaus perforation here. And the first thing they're doing here is going right into the cavity. And they're really cleaning out this cavity as much as possible. And you've got to invest a little bit of time and energy at the start to do this bit. This patient, interestingly, was treated with the Esosponge. That's a intracavity sponge, which you change more frequently. And this patient, unfortunately, was very, very resistant to this procedure. You can see after 6 weeks, there's still a very established defect here after 8 sponge exchanges. So I think they were trying to do something different for this very difficult patient. So they've deployed the stent over a wire. You have to be pretty careful with your markings here. So you actually want to have your scope side by side when you're deploying the stent here. And if you've got the benefit of radiological support as well, they encourage you to use that. So really the key here is you want your sponge to cover the defect. And remember, the sponge is 5 centimeters. So any defect bigger than that, it's going to be really a contraindication for the sponge. If anything, it's okay to deploy the sponge slightly south and bring it further up if necessary, instead of the other way around. You can see there's a loaded suction tube, and the benefit is that the patient can have a soft and oral diet as well with the sponge. This is the removement a week later. So a distal transparent cap is being used to very carefully remove the sponge, and then you would remove it as you would any conventional stent. And you've got to be very careful at this stage to make sure that you really have released the sponge from the defect so you don't propagate the tear any further. What's your thoughts on this device, Ryan? Do you see a role for it?
Yeah, I think it's really interesting. Negative pressure tissue healing has been used in a lot of other disease states. I think there's a few reflections here. There is no data yet on this at all. We started using the sponge, and this is very work intensive. And I think that one is you need to change the sponge. I'll talk about the VAC stents in a second. Is every 3 to 5 days. And it's really important that they're on constant negative pressure. And by negative pressure, I mean, between 100 to 120 millimeters of mercury negative pressure, and that needs to be on, it cannot drop. If you lose that even for a second, then you've lost the entire effect. So the data on this will evolve. I mean, I think an acute bore halves like that, like that showed my preference would not be to use this. I would suture that close, and we have data that shows that actually that's not it's a good outcome for a lot of patients. The VAC stent is really exciting. I think that for bigger chronic fistulae, it may very well help. I have some reservations about how easy it is to remove the stent. I've been on a live case about 6 months ago where, just removing the stent causes subsequent laceration. But I think negative tissue pressure is something that we have to look at in these chronic fistulae. And I think that, that this is almost a new course that you and Dave need to run, management of holes. Often closing these holes is not the right thing to do, and you just need to let them lay open, and you just need to drain the cavity with an intercostal drain. But yeah, look, exciting new technology. Congratulations for showcasing it here. I think it's the first time we've seen it, and I suspect this time next year this will we will be using this more, and our data will grow in terms of when's the right time to use them, how often we need to change them, and where it will work the best.
Yeah, brilliant. So look, I think we've discussed so much today. It's been a brilliant day. We've had a real excellent collection of talks from faculty, both nationally and internationally. We've had experts really share some really engaging opinions and actually ask a lot of questions. One of the great things about these virtual courses is that we can have a lot of time for question and answers, and I think that's where the most sort of interesting and stimulating part of the course for me. So I'd like to thank first my colleague Rehan Haidari for all the support you've offered today. It's been a great course. And thank all the faculty again. I'd like to thank our industry partners, without whom this wouldn't be possible. So thank you for all of your support. I would encourage all the delegates to, at their own time, go onto the Gastro Learning platform and look into the industry partners' websites and really look at some of these devices that we've discussed in detail today, and really spend some time, make communications with the reps, and really see if we can introduce these technologies into your practice where appropriate. Please don't forget, you can go back and watch today's course on demand whenever you want, and you can share the link with friends. So it's a great thing, and we look forward to bringing it again in the not too distant future. Rehan, any last words before we close up?
Yeah, look, it's 8 hours on. We're still going. I've learned a lot. Thank you to everyone who's taken part. I think a big congratulations to you and David. Graham for putting this course together. 7 years ago when I first put this as a concept together, I never thought it would grow, and it gives me great happiness to hand this over to you and David to run in due course, and just congratulations, and thank you to everyone who's taken part, and thank you for the great day.
Thank you, man. So with no further ado, we'll call a wrap on the day today. Good evening everybody from London, and look forward to seeing you again soon. Bye-bye.